Hi, good evening all. So this week is about sepsis and antimicrobials. So Dr. Sananta is supposed to take a class, but because he was busy, he will be giving his recorded class, and you can access it by maximum by tomorrow morning. Okay. So we'll be starting with mechanisms of antimicrobial resistance today. So what is an antimicrobial resistance? It is the potential of the microorganisms, it could be bacteria, viruses, fungi or a parasite, to thrive and continue to grow in the midst of the drugs designed to kill them. This is simply defined as resistance. So before going into the resistance topic proper, we'll just briefly see the common classes of antibiotics which we use in practice. Okay. So usually most of the antibiotics fall into this four group of mechanisms of actions. Number one, it could be cell wall inhibitors. Two, protein synthesis inhibitors. Three, DNA synthesis inhibitors. Four, folic acid metabolism inhibitors. So cell wall inhibitors, the group of antibiotics are beta-lactams, carbapenems, cephalosporins, monobactams, penicillins, glycopeptides. The antibiotics which could depolarize the cell membrane, lipopeptides. Protein synthesis inhibitors, which binds to 30S ribosomal subunit, aminoglycosides and tetracyclines, which bind to 50S ribosomal subunit, chloramphenicol, lincosamides, macrolides, oxazolidiones, streptogramins. And antibiotics which inhibit nucleic acid synthesis, quinolones, fluoroquinolones, which inhibit the metabolic pathways, sulfonamides. So knowing the four groups is important because that is when how the resistant mechanisms gets altered to inhibit these antibiotics not to act, which we will understand. So this is a picture showing us the various group of mechanisms of actions. We saw cell wall inhibitors like beta-lactams, glycopeptides, phosphomycin, bezitracin, and cell membrane synthesis inhibitors, lipopeptides, folate synthesis inhibitors, sulfonamides, protein inhibitors, protein synthesis inhibitors. We saw a set of antibiotics which inhibit the nucleic acid, which is fluoroquinolones, rifampicin, and RNA synthesis inhibitors, ansamycins. This is a gist of what we discussed before. And among the antibiotics, beta-lactams, aminoglycosides, glycopeptides, quinolones, streptogramins, and lipopeptides are considered to be bactericidal agents, whereas chloramphenicol, oxazolidiones, sulfonamides, tetracyclines, macrolides are bacteriostatic agents. So let us discuss the topic proper. So a bacterial isolate is considered non-susceptible to an antimicrobial agent when it is tested resistant, intermediate or non-susceptible when using clinical breakpoints as interpretative criteria. So the susceptibility and the resistance are usually measured as a function of minimum inhibitory concentration. So based on that, the resistant bacteria could be multi-drug resistant, XDR or pan-drug resistant. Multi-drug resistant, any gram-positive, gram-negative bacteria resistant to 3 or more antimicrobial classes. That is when they are called MDR. That is non-susceptibility to at least one agent in 3 or more antimicrobial categories. That is when they are called MDR. Extremely drug resistant groups are non-susceptibility to at least one agent in all but 2 or fewer antimicrobial categories. That is, bacterial isolates remain susceptible to only 1 or 2 antimicrobial categories. Pan-drug resistant, which is non-susceptibility to all the agents in all antimicrobial categories. No agent tested as susceptible for the organism. So MDR, non-susceptibility to at least one agent in 3 or more antimicrobial categories. Extremely drug resistant, where the bacterial isolate is susceptible only to 2 or more categories. Pan-drug resistant, not susceptible to any of the antimicrobial group. Coming on to the mechanisms of antimicrobial resistance. I know there are going to be many names of the genes and porins and efflect pumps names. It may be boring, but it is important. Per se, for exams, they might ask what are all the mechanisms. You can just remember the significant ones. You can listen to the class, make a note, just know the names of significant ones, and at least 4 or 5 you can reproduce in the paper. You will definitely get good marks. So there are going to be many gene names, efflect pumps name, porin names. It may be boring, but it is important. Whatever is important only I have put. If you could see these slides and listen once and make a note, this is more than enough for your exams as well as practice. So coming on to mechanisms. So there are 2 mechanisms. One is chromosomal gene mutations and various modifications happening at various levels. So the chromosomal gene mutations can be of 3 types. One is mutations of the genes encoding the targets of the antibiotic, mutations of the gene encoding the transporters of the antibiotic, and the genes encoding the regulators that repress the expression of the transporters. For example, antibiotic modifying enzymes in case of aminoglycosides and efflux pumps in case of tetracyclines. And the acquisition of foreign DNA through horizontal gene transfer that codes for resistant determinants is also another mechanism. Coming on to genetic, bacteria exhibit antibiotic resistance having genes can come from 3 methods. One, it could be intrinsic, one, it is acquired, one, it is adaptive. So intrinsic resistance is when the bacteria's inherent natural capacity to show resistance to certain groups of antibiotics due to the presence of their own chromosomal genes without mutation or gain of further genes. So the bacteria will show inevitable resistance against certain antibiotic if used to treat infections by them. Efflect pumps and reduced permeability are commonly involved mechanisms in intrinsic resistance, but it could also be associated with multi-drug efflux pumps frequently. So this is the table showing various antibiotics, why they are intrinsically resistant, because of what mechanism. So aminoglycosides are intrinsically resistant to act on anaerobic bacteria because there is no oxidative metabolism for uptake of the antibiotic. And in case of chloramphenicol, resistant against lactobacilli and leuconostoc because of lack of appropriate cell wall precursor target to allow binding and inhibit cell wall synthesis. Metronidazole, it will not act on anaerobic bacteria because unable to reduce the drug to its active form. Vancomycin will not act on gram-negative bacteria because of its intrinsic resistance. Why? Because the outer membrane is impermeable to the large glycopeptide. Sometimes vancomycin will not also be able to act on some of the enterococci species where there is lack of sufficient oxidative metabolism to drive the uptake of the glycopeptide antibiotics. And beta-lactams may not be able to act on some of the enterococci because of lack of penicillin binding proteins that effectively bind and are inhibited. Beta-lactams may not be able to act on some of the gram-positive bacteria because of lack of penicillin binding proteins. And beta-lactams may not be able to act on Stenotrophomonas or Maltophilia because antimicrobial agents, these bacteria can produce beta-lactamases that could destroy the beta-lactam ring so that the beta-lactam may not be able to act on them. Ampicillin may not be able to act on Klebsiella because it produces beta-lactamases which breaks the ring. Carbanicillin may not be able to act on Pseudomonas aeruginosa because of lack of uptake causing lack of intracellular concentration and an inability of the antibiotics to achieve effective concentration. Coming on to acquired resistance. It is an evolutionary process of exhibiting the resistance by a previously sensitive bacterium due to acquisition of chromosomal gene mutation or gaining an exogenous new genetic material via horizontal gene transfer. So there are three main mechanisms of horizontal gene transfer: transformation, transposition, and conjugation, wherein plasmid mediated method is the most common one used in most of the acquired resistant patterns. And one good example is that escape organisms in ICU, which are called superbugs, which we will discuss in the end. So as I told you, the gene transfer could be vertical or horizontal. Horizontal is important for us, wherein you can see during replication, the bacteria can transfer a resistance gene contained in the plasmid from a parent cell to the next generation. That is as in case of vertical transmission. The horizontal transmission in bacteria can be mediated by three principal mechanisms, that is transformation, transduction, and conjugation. Transformation is nothing but uptake of the free DNA by the next daughter cell. Transduction is nothing but virus mediated, bacteriophage mediated gene transfer. And conjugation is the transfer of DNA through a close contact between the donor and the recipient bacteria. Coming on to adaptive resistance, it is kind of a temporary bacterial resistance, which is a phenotype that is conditional to the environmental changes both in humans and livestock. For example, sub-inhibitory concentrations of the antibiotic may make the organism resistant to a particular antibiotic. Okay, or some of the environmental signals, such as in cases of during culture analysis, like growth factors, nutrition, stress, pH, concentration of ions in the lab, could cause this type of resistance. It develops transiently and generally reverts back to the original state upon removal of the inducing signals, like giving proper inhibitory concentrations of the antibiotics, or just avoiding all of these stress, pH changes, concentration of the ion changes in the lab. The possible causes could be high mutation rates, gene amplification, efflux pumps, biofilm, epigenetic inheritance, population structure, and heterogeneity. So this is a picture depicting the various types of antimicrobial resistance, which we will discuss now. So as I told you, this is the picture showing the various mechanisms of actions of the antibiotics, where these are the types of the antimicrobial resistant patterns, which we will discuss now. So the first method is the modification of the antibiotic molecule. Modifications of the antibiotic molecule can happen in two ways. One is by chemical, wherein structural changes in the molecule can prevent the antibiotic from binding to its target. The second method is destruction of the antibiotic molecule by any specific bacterial enzyme, which will prevent the action of the antibiotic. So chemical, it could be of three types, like it could be acetylation or addition of an acetyl group to some of the antibiotics, making them unable to bind to that particular target. Phosphorylation, which is the addition of the phosphate group, which may make the antibiotic prevent binding to its target site. Adenylation, which is the addition of the adenylyl group, especially in aminoglycosides and lincosamides, which will prevent the target action. So this type of chemical changes is usually seen with antibiotics, which usually act on protein synthesis, that is aminoglycosides, lincosamides, oxazolidiones, and tetracyclines, some of the groups. So acetylation, affected antibiotics are aminoglycosides, chronomphenicol, and streptogramins. The enzymes involved are acetyl transferases, wherein I told you there is an addition of the acetyl group, which will change the target. So this type of mechanism is seen with gram-negative bacteria, especially Enterobacteriaceae. Phosphorylation, aminoglycosides and chloramphenicol. The enzymes involved are phosphotransferases, where the phosphate group attachment limit the drug efficacy by altering the binding capability, usually seen in some of the gram-positive bacteria like Staphylococcus aureus. Adenylation, the affected antibiotics are aminoglycosides and lincosamides, wherein the enzymes involved are adenyl transferases, where an adenyl group is added, which may change the target, usually seen in gram-negative bacteria, might be Pseudomonas aeruginosa. So the second modification we saw was destruction of the antibiotic molecule. So some of the organisms can produce enzymes called beta-lactamases, which may hydrolyze the beta-lactam ring, which is crucial for the antibiotic activity. Once the ring is broken, the antibiotic molecule can no longer bind to its target, rendering it ineffective. So as we know, generally the group of antibiotics, generally the beta-lactamases antibiotics can be divided into based on serine proteases, metalloproteinases, functional classification, structural classification. But before that, this is a simple classification. Cephalosporinases, ESBL and carbapenemases, which we commonly use in day-to-day practice. And let us see individual ones. Cephalosporinases are the enzymes which usually hydrolyze the cephalosporins and related beta-lactam antibiotics, preventing them from inhibiting the bacterial cell wall synthesis, which may limit the use of cephalosporins for treating specific infections. So in such cases, you may have to go ahead to treat with carbapenems or a combination therapy. ESBL are a spectrum of enzymes which hydrolyze the broad range of beta-lactams, including penicillins, first, second and third generation cephalosporins, and also aztreonam, rendering them ineffective. So we may not be able to use the beta-lactam antibiotic. We may have to use carbapenems or BL-BLI combinations. Carbapenemases are the enzymes which hydrolyzes the carbapenems along with other beta-lactams which are described above. So it may limit the effectiveness of carbapenem. So we may have to move on to the newer antibiotics like polymyxins, tigecyclines and other pipeline antibiotics for the effectivity. So cephalosporinases are the ones which hydrolyze cephalosporins. ESBL are the ones which hydrolyzes penicillins, first, second, third generation cephalosporins and aztreonam. Carbapenemases are the ones which hydrolyzes carbapenems. So coming on to the specific classification of the beta-lactamases. So it can be classified in two ways. One is Ambler molecular classification. The other one is Bush-Jacobi functional classification. So the molecular classification is based on the serine proteases and the serine proteases beta-lactamases and the metallo-beta-lactamases. The serine proteases classes could be class A, class C and class D. And the metallo-beta-lactamases class is class B. In class A, we have the classical narrow spectrum beta-lactamases, ESBL beta-lactamases, which are named as STEM, SHV and CTXM, and also class A carbapenemases like KPC, SHV and SFC. Class C group of beta-lactamases is also called AMC beta-lactamases, wherein it has extended spectrum AMC. Class D is also consists of ESBL beta-lactamases, that is the extended spectrum beta-lactamases, oxacillinases and carbapenem hydrolyzing class D beta-lactamases. So in class A, class C and class D, the important point you have to remember is all three have a set of enzymes which could hydrolyze the carbapenems called carbapenemases, which is important in the treatment of MDR microorganisms. Coming on to class B, which are called metallo-beta-lactamases, which is resistant to most of the antibiotic groups, wherein they have B1, B3, B2 groups, where B1 consists of IMP, VIM, SPM, IND, NDM, DIM, GIM, SIM enzymes. B3 has AIM, COB, FES enzymes. And B2 has CPHA, SFH1 and IMIS enzymes. Where in this metallo-beta-lactamases could also cause carbapenemase activity. Coming on to the functional classification, It is nothing but a mixture of all 4 classes of Ambler molecular classification, where Bush-Jacobi classifies as group 1, group 2, group 3. Group 1 has cephalosporinases, group 2 has serine beta lactamases, and group 3 has metalla beta lactamases. So this is a table wherein both the classifications are mingled together to make a table, where this is the Bush classification, the functional classification, that is 1, 2 and 3. This is the Ambler classification based on metallo and serine proteases. It is CAD and B. So in functional group, the group 1, that is the cephalosporinases, belong to the AMP-C group of the Ambler's group. And in functional group, the penicylases and cephalosporinases belongs to group A and D of the Ambler's group. And the metalla beta lactamases of the functional group belongs to the group B of the Ambler group. And there are also a set of organisms called spice organisms, where these are the gram-negative bacteria that have inducible chromosomal beta-lactamase gene known as AMP-C. So the resistance may not be detectable initially, but they will appear after a period of exposure to the beta-lactam antibiotics. The organisms could be remembered as a acronym mnemonic of SPICE, that is Serratia, Providentia, indole positive species, that is Proteus, Morganella and Providentia, Acinetobacter, Citrobacter and Enterobacter species. So this is a table showing us the Bush-Jacobi classification, Ambler's classification, which we discussed along with the enzymes. This table additionally shows that the beta-lactam inhibitors. The common beta-lactam inhibitors are clavulanic acid, sulbactam, tazobactam. So you can see that the group B, that is the metallo-beta-lactamases, is resistant to most of the beta-lactam inhibitors. Let it be clavulanic, tazobactam, sulbactam. It is like resistant to most of the beta-lactam inhibitors, but sometimes it could be inhibited by monobactams, that is the aztreonam. But here you can see there are variable inhibitory patterns which you can go through in the table. So the second mechanism we are seeing is decreased antibiotic penetration and efflux mechanisms. So in gram-negative bacteria, the targets is usually located in the outer membrane, that is the cytoplasmic membrane. Okay, so this cytoplasmic membrane has to be penetrated by the antimicrobial agents to have their target actions. Okay, so how does the gram-negative bacteria creates a defense? It prevents the antibiotic from reaching its intracellular or periplasmic target by decreasing the uptake of the antimicrobial molecule. So how does it do that? Either by means of pore-in channels or by means of efflux pumps. So what is the effect on hydrophilic molecules here? Some of the beta-lactams, tetracyclines and fluoroquinolones use water-filled diffusion channels called pore-ins to cross this cytoplasmic membrane. So whenever there is a pore-in, when the expression of the pore-in is less or when the pore-ins are modified, so automatically the antibiotic cannot enter into the periplasmic space. And vancomycin, a glycopeptide antibiotic, is not active against gram-negative organisms mainly because it cannot penetrate through the outer membrane. Innate low susceptibility, like examples like Pseudomonas and Acinetobacter baumannii have innate low susceptibility to beta-lactams because of the reduced number or differential expression of the pore-ins. So coming on to pore-in mediated antibiotic resistance, there are various type of pore-ins like trimeric, monomeric pore-ins, and they can also be classified based on selectivity and regulation of their expression. So what could happen to play as a defense mechanism to prevent the antimicrobial to enter? What all could happen in the pore-in? There could be alterations of the pore-in. There could be a shift in the type of the pore-in expressed. There could be a change in the level of the pore-in expression. There could be impairment of the pore-in function, or it could be associated with other mechanisms like efflux pumps and enzyme destruction. So examples of such a mechanism can be seen in E. coli, wherein they have this OMP-F, OMP-C and 4E pore-in channels, which could prevent the antimicrobial agents to enter. And Pseudomonas aeruginosa as OPR-D protein, which is usually used for the uptake of the basic amino acids and antibiotics, where this porin can get altered or the expression could be impaired to prevent the antimicrobial agent to enter. In case of Klebsiella pneumoniae, the porin channel is called OMK. So there were studies where Klebsiella pneumonia were recovered before and after the antimicrobial therapy, where the post-therapy isolates were found to exhibit a shift in the porin expression from OMK35 to OMK36, later possessing the smaller channel size. So once the antibiotic is administered, the porin channel is rapidly getting altered to prevent the entry of the same antimicrobial agent to act on the bacterium. So there is 4 to 8-fold decrease in the susceptibility for a wide range of the beta-lactam antimicrobials in case of Klebsiella pneumoniae. So other organisms which could manifest the same feature could be Salmonella, Neisseria and Acinetobacter baumannii. Coming on to the next mechanism, that is efflux pump. So production of the complex bacterial machineries capable of actively extruding the toxic compounds out of the cell. That is the function of the efflux pumps. They also reduce the intracellular concentration of the antibiotic, thereby preventing them from reaching their target sites and exerting their therapeutic effects. So efflux pumps again could be of 5 major families. One is major facilitator superfamily, small multi-drug resistance family, the resistance nodulation cell division family, that is the RND type, which is most commonly seen in the gram-negative bacteria, and ATPase binding cassette family, again the second most common, and multi-drug and toxic compound extrusion family. So these are the efflux pumps belonging to the 5 families which can be seen in the gram-positive and gram-negative bacteria. So what are all the antibiotics which could get affected by this? One is tetracycline, which is a very common antibiotic resistant mechanism, where there are TET efflux pumps belonging to the major facilitated superfamily, which can exclude the tetracyclines using proton exchange as the source of energy. So 20 TET genes have been described till now, most of which are harbored in the mobile genetic elements. That means which can transfer this material to the daughter cells consistently. So this is usually seen in gram-negative organisms than the gram-positive organisms, and the names of the efflux pumps could be TET-K and TET-L. But the same tetracycline efflux pumps may not decrease the minocycline tigecycline susceptibility. So this can be used as an alternate agent. And the MDR efflux pumps such as ACR-AB Tol-C in Enterobacteriaceae and MEX-AB OPR-M in Pseudomonas aeruginosa are able to extrude the tetracyclines, causing multi-drug resistance. Next efflux pumps which could affect the antimicrobial agents are the RND pumps. They are nothing but proton antiporters which could span the cell membrane fully to expel the drugs. But the normal function is that it can even exclude other several toxic compounds such as bile salts, cationic dyes, disinfectants, along with antibiotics also. So this RND pumps can be seen in E. coli, where the name of the pump is ACR-AB Tol-C, and other tetracyclines, chloramphenicol, and some beta-lactams, fusidic acid, fluoroquinolones can also have this type of RND pumps. Coming on to macrolide resistance, where MFA and MFG genes are the ones which could alter this pumps, which is usually seen in gram-positive organisms. It does not result in cross-resistant to lincosamides or streptogramins. Coming on to MSRA and MSRC genes inducing the pumps, where there is low-level resistance to macrolides in streptogramin B, which is usually seen in Staphylococcus epidermidis and Enterococcus fecalis. And there is also LSA LSA gene which could alter the RND pump, seen as an intrinsic resistance of Enterococcus fecalis to lincosamides and streptogramin A. Coming on to the next mechanism, which is the modification of the target site, which may enable the bacteria to survive the antibiotic exposure by reducing or completely eliminating the drug's ability to bind to its intended target. So this can happen in 3 ways. One is mutational changes in the target genes, or enzymatic alteration of the target size, or target protection mechanisms. So the first one is the mutation seen with fluoroquinolones, where mutations in the GYR-A and PAR-C genes, which encode the DNA gyrase and topoisomerase 4, which is the major target for fluoroquinolones. When this mutation happens, there is reduced fluoroquinolone binding, and accumulation of the mutation can increase the level of the resistance. In case of linezolid, mutations in the 23S RNA and ribosomal protein, which is the target for linezolid, which may reduce the linezolid's ability to bind and inhibit the protein synthesis and cause resistance. Coming on to rifampin, mutations in the POB gene encoding the beta subunit of the RNA polymerase, which could prevent the rifampin binding and cause resistance. So the second method, that is the enzymatic target site modification method, where enzymatically modifying the target sites of the antibiotics can prevent the effective drug binding and action. So some of the enzymatic methods are methylation of the 23S rRNA, which could cause macrolide resistance, enzymes encoded by erythromycin ribosomal methylase genes, and methylate adenine of the methylene adenine residues in 23S RNA. This methylation hinders the binding of the macrolides, lincosamides, and streptogramin B antibiotics, can lead to cross resistance with this antibiotic classes. So this type of process can be seen in Staphylococcus aureus, Streptococcus pneumoniae, and other gram-positive bacteria. Then comes CFR mediated resistance, where CFR enzyme encoded by the CFR gene methylates the 23S RNA at the position of A2503, where this modification can affect the binding site of linezolid and other antibiotics. It can also create cross resistance to phenicols, lincosamides, and streptogramin. So this type of mechanism is seen in Enterococcus faecium and Staphylococcus aureus. The next enzymatic alteration is with alteration of DNA gyrase and topoisomerase 4, which we already saw with the mutational method, where QNR proteins protect the DNA gyrase and topoisomerase 4 by competing for the binding site. So this will again reduce the quinolone effectiveness. This is usually seen in Klebsiella and E. coli. Ribosomal methylation and streptogramin resistance, where there is methylation of 23S RNA by specific methyl transferases, which could lead to streptogramin resistance, which is seen in streptococci and staphylococci carrying genes. The third method is target protection, wherein the resistant mechanisms where specific proteins, often encoded by genes located on the mobile genetic elements, prevents the antibiotics from effectively binding to their bacterial targets. So it can be seen with tetracycline resistance, where TET-M and TET-O are homologous of elongation factors used in protein synthesis. They interact with the ribosome and displace the tetracycline from its binding site, allowing the protein synthesis to continue. So you can see here that only the antibiotic is mobilized out of the target site, but the bacteria can use the changed protein substrates to continue its protein synthesis. TET-M directly dislodges the tetracycline by interacting between the domain 4 of the 16S rRNA and the tetracycline binding site, altering the ribosomal conformation to prevent rebinding. Coming on to fluoroquinolone resistance, which we already discussed, the QNR protein are homologous protein substrates which can bind to the protein chain and continue with the protein synthesis, which may displace the fluoroquinolones and reduce its effectivity. And the next method is complete replacement or bypass of the target site. This is usually seen with that folic acid metabolism or the metabolic metabolism targeting antibiotics. So survival by either replacing the original antibiotic target with an alternative molecule or creating a bypass pathway that circumvents the need for the targeted cellular component or process. So this is usually seen in MRSA and with the cotrimoxyl, that is the dihydrate folate reductase variants. So with MRSA via the MEK-A gene. So the MEK-A gene, which encodes an alternative penicillin binding protein that is called PBP2A, which has a low affinity for beta-lactam antibiotics. But this PBP2A can perform the essential cell wall synthesis, function of the penicillin binding protein despite the presence of methicillin, rendering the beta-lactam antibiotic ineffective. So this MECA gene is carried on a mobile genetic element called staphylococcal cassette chromosome MEC cassette, and it happens through horizontal transfer, and this type of mechanism is seen in Staphylococcus aureus. Coming on to vancomycin resistance via alternative peptidoglycan precursors. So there are modified cell wall precursors that end in D-ALA-D-LAC instead of D-ALA-D-ALA, where vancomycin binds poorly to D-ALA-D-LAC. So it prevents the vancomycin from effectively inhibiting the cell wall synthesis. So this is also plasmid mediated, and it is mostly seen in enterococcal species. Coming on to the next examples, trimethoprim resistance via DHFR variants which could bypass. The DHFR reductase variants reduce the affinity for trimethoprim compared to the native DHFR enzyme. This is also plasmid mediated, and it is seen in Enterobacteriaceae. And bypassing of the folate synthesis pathway via exogenous folate. So the bacteria will start utilizing the exogenous folate from the environment rather than going through the dihydrofolate reductase enzyme. So it bypasses the need for folate synthesis pathway targeted by the sulfonamides. So sulfonamides may not be able to act on those bacteria, which is usually seen in gram-negative bacteria. So this completes overall our mechanisms of antimicrobial resistance. I know it might be extensive, very difficult to remember. I would want you to just go through again slowly and make a note of it so that you can present this and understand even for clinical practice. So let us just briefly see about the multi-drug resistant organisms in the ICU and what are all the common resistant mechanisms which is seen in them. It is more or less the mixture of same things which we discussed till now, but I just specifically wanted to put the specific organisms because this we see day to day in practice. So I thought we should understand this. So there are some group of organisms called superbugs in the ICU, which are typically multi-drug resistant organisms, which may give us definite challenges to treat them because they are resistant to most of the antibiotics and very difficult to treat and control. And one such example is escape group of organisms. So let us just briefly discuss about the antimicrobial resistant mechanisms in them. The first organism in escape is Enterococcus faecium. It can have vancomycin resistance due to VAN gene clusters. It can have beta-lactam resistance mediated by penicillin binding protein PPB5. It can have aminoglycoside resistance through AEC, that adenylation process genes. So these are the common resistance genes involved. So the genetic transfer through plasmids and transposons with biofilm formation, aiding persistence in healthcare environments and giving us a tough time to treat these organisms. The second organism in the escape group is the Staphylococcus aureus, that is MRSA. So it can have methicillin resistance with intrinsic mechanisms like efflux pumps like QuAC-A and or NOR-A efflux pumps, or it could be because of overproduction of beta-lactamases or biofilm mediated resistance. And the enzymes involved are these. So the biofilm formation and the genetic mutation allow the organism to survive in adverse conditions, and the resistance is often mediated through horizontal gene transfer. This is what I was telling you, the most common mechanism is horizontal gene transfer, that is plasmid mediated. Then comes Klebsiella in escape group, where the carbapenem resistance happened because of the beta-lactamases production. Like we saw a set of the carbapenemases enzyme, it could be Kpc or metalloid beta-lactamases or group D beta-lactamases. So it can be resistant against carbapenem, cephalosporins and aminoglycosides. So hypervirulent stains with capsule formation aid in the immune evasion. Then comes the Acinetobacter baumannii, where it can have carbapenem resistance through carbapenemase enzymes as per the group we saw. And it can also have efflux pump overexpression and membrane protein modification mechanisms. So these are all the genes involved. And the enzymes, it could be resistant, the antibiotics, it could be resistant, could be carbapenems and cephalosporins. So we saw efflux pump systems, porine modifications and carbapenemases All this create a strong resistance in Acinetobacter baumannii. And then the next organism in escape group is Pseudomonas aeruginosa, wherein there is intrinsic resistance via reduced membrane permeability, which we saw in intrinsic resistance. And there could be AMP-C beta lactamases, or there could be efflux pumps, where it is resistant against carbapenems, cephalosporins, and fluoroquinolones. So efflux pump overexpression and membrane protein modification are the major things which could end up creating the MDR pattern. The last organism in escape group is E. coli, where resistance can happen through ACR, AB, TOL-C efflux pumps, pore protein mutations, and genetic mutations in quinolone resistant determining regions. And the enzymes, genes involved are these. And the antibiotics that could be resistant against are fluoroquinolones, aminoglycosides, and carbapenems, where efflux pumps and target site modifications are the major mechanisms in E. coli, which is creating the resistance. So what are all the strategies we could follow to avoid this mechanism patterns? One is a strong antimicrobial stewardship protocol in individual ICU as per the local antibiogram organism. That is the first step. And along with that, these are some of the methods which could be tried in cases of the multi-drug resistant patterns, wherein we can look for antibiotic synergies, where some groups can be combined, which could act on the resistant pattern and help reducing the resistance, where newer antibiotics in the pipeline can be used, where we saw that the same tetracycline group may not be resistant to tigecycline, eravacycline, minocycline, where the other alternative antibiotics can be used. And biological alternative therapies like the sporin inhibitors or the molecular level modification therapies can be tried. And new carriers and antibacterial systems, especially again at the molecular level, can be tried. And physical and chemical therapy, again at the molecular level, can be tried. And these are some of the strategies which could reduce antimicrobial resistance. So this completes our mechanisms of antimicrobial resistance. I know there are no major doubts to ask. It is just theory, but I would like you to just listen again and make a note. I'm telling this repeatedly because there could be questions like resistant patterns on escape organisms, something like that. Just I would want you to just make a table quickly. By listening to the class, you can just write a note and you can keep it as a short note for your exam use as well as for the practical use. So the next speaker can take over.
Ma'am, once I call Dr. Tapas.
Yeah, sure, yes.
Okay.
ഇത് കണ്ട സ്നേഹിക്കിനെ ഫുള്ള്
It's a fish man.
Novin, can you please mute?
Hey, don't touch.
ഇത് കണ്ട ഓടിപ്പോവും ഇത് കണ്ട ഇത് ഓടിപ്പോവും
Dr. Navin, you can mute yourself.
മുഴുവൻ പാമ്പ
Evening, sir.
Good evening, good evening. So we'll be starting. I think Dr. Bhuvneshwar, you have finished?
Yes, sir. The mechanisms of antimicrobial resistance is done, sir.
Okay, so I will be talking about biomarkers as well as immunomodulators. Okay, yeah, perfect. Is my screen visible?
Yes, sir. Yes, sir.
Okay, perfect. Okay, good evening, all the attendees, and we are today going to discuss about two important topics in sepsis, which would be not only useful for you like to address and appear in the exam, but also in the practical as well as in your day-to-day clinical practice. So the first one is biomarkers in sepsis, and the second one, which I would be talking about, is immunomodulators in sepsis. We all know that the biomarkers in sepsis is a vast topic and is always updating. I would say every day there is something about other coming up in the biomarker section. But I would be keeping myself restricted to the exam perspective because it would not be prudent to discuss about the recent advances as well as the detailed controversies of all the biomarkers. But I would be also touching upon something which would be interesting to all of you. Now, first question which come to in our mind when we are talking about sepsis, why biomarkers matter in sepsis? Is there anything special that would be helpful in our day-to-day sepsis management? The first thing that would be very important is the complex pathophysiology of sepsis that is involving diverse mechanisms, phenotypes, making the diagnosis and the management part very challenging. Patients present varying of symptoms and the treatment responses are also not very clear and the outcomes are also unpredictable. So the point number one, to use biomarkers, or I would say biomarkers would be coming as a holy grail, is the complex pathophysiology. Now there are certain current limitations of the sepsis management as we do not know what is the gold standard for sepsis diagnosis. Though we try to use blood culture as the gold standard for pathogen detection, but that is only positive in 30 to 40% of the sepsis cases that we all understand. Now, the last one, though we may get sometimes like the culture reports positive, but that would be coming up with two or three positive reports like the multiple pathogens should be positive. So how to treat that, whether to add on antibiotics or antifungals for that, or we would be also sometimes surprised to get the culture reports coming as sterile, though the patient is not doing good, patient is on multiple inotropes, vasopressors, patient is really sick. So in that situation definitely we need something which would be actually acting as the lamp post, or I would say the something which would be helpful to use at the bedside. Now, the lack of tools are there for the treatment selection. If we have also selected at the very first instance, but how to evaluate it and how to go for escalation or de-escalation, that we are also sure. And there is not proper risk assessment or outcome prediction with existing the diagnostic modalities. Now, the role of biomarkers would be definitely helping us for the personalized medicine, and that would be tailoring our treatments based on each patient's unique biological profile. And that would also, if we are getting the right one, that would be improving the accuracy in the diagnosis, risk profiling, and also it's not only related to the treatment as well as the management plan, but also predicting the prognosis. Now, one line about what are the biomarkers. If somebody will be asking that, can you just define biomarkers? It's a naturally occurring molecules, genes, or characteristics used to identify physiologic or pathologic processes. Now, this is something which would be aiding the clinical decision making by providing actionable insights. So we'll definitely get some or other help to diagnose or the treat or manage or prognosticate our patients at the bedside. Now, on that basis, there are types of biomarkers which would be definitely you have to remember and answer also. There may be a question which would be not only related to biomarkers in any specific disease, but it would be coming as a general question also, biomarkers in critical care. So that also you have to keep in mind. So you can also mention this slide in any of the biomarker related to any of the organ that may be asked in your exam. So the first biomarker is diagnostic biomarker. Now, diagnostic, the name itself implies that we have to discriminate between sepsis and non-infectious critical illness. Now, that would aid in identifying the causative organism as it is diagnostic. So definitely we need to know the diagnosis, and also it would be improving antibiotic stewardship by reducing unnecessary use of the antibiotics or antifungals. Now, there is another form of biomarker which is named as prognostic biomarker. Definitely diagnostic, then there will be prognostic. And as the name implies, it will predict the outcome, and also it would help us to stratify patients into risk profiles. This would be definitely enable personalized therapy by identifying subgroups based on the specific pathophysiology. So it would be definitely helpful for getting the phenotypes of the sepsis. As the sepsis is a, like, no, I would say dustbin diagnosis nowadays. So we need to have something which would be like making it more structured, standardized, and also phenotype based. Now, the third important thing which is right now coming up in a big way is theranostics biomarkers. As the name theranostic, it would be mainly for the therapeutics. So that would be more of personalized therapy. Now, it would be selecting and evaluating targeted therapy. So we cannot like just give one umbrella of antibiotics, or like no one standard blank sheet of like no antibiotic which would be like having 1 gram positive, 1 gram negative, one atypical, one antifungal. It cannot be like that. It has to be evaluated based on the targeted therapy. Now, the second one would be, it would be monitoring the therapy effectiveness using easily obtained samples like blood or urine. So you get some sample, you get the biomarker in that, and on that basis, you can modify or like tailor-made your like the treatment protocol. Now, this will be also enabling real-time stratification of patients for personalized and targeted treatment. So this is something which you need to remember. Now, this is very interesting, like no picture that I got, which would be very easy to remember. So we are here at the left side at the clinician. Now, use of biomarker. We all know biomarker would be B for V, bedside test in simple obtainable sample, that would be blood or urine, that affects the clinical decision. Now, the types of biomarker, as we have already discussed, it would be diagnostic, prognostic, theranostic. Now, what are the important uses of diagnostic? We have already discussed infectious versus non-infectious, causative organism, antibiotic stewardship. Prognostic, assigning the risk profile, predict the outcome, stratify based on the pathophysiology, and theranostic would be more for the therapeutics. Select and evaluate specific therapies, and that would be key to the personalized medicine. Now, what should be the ideal feature of the sepsis biomarker? Any biomarker that should be having at least some of the characteristics. Otherwise, we cannot like accept that yes, that can be one of the biomarker. The biomarker that we would be selecting, that has to be present at the symptom onset or even earlier. If the patient is starting to be like rising in the temperature, so your biomarker should be present at that time itself, or maybe before that. Now that would be allowing for an early diagnosis. Clear? Now the second one, the biomarker has to be highly sensitive and specific for the infections, and that would be also allowing for an accurate differential diagnosis between infectious and non-infectious disease. If we are confused whether this should be treated or not from the sepsis point of view, so that should be helping me at the bedside rather than confusing me. Now, the third point is it has to be capable of identifying the organisms also. If I am getting to know that my patient is having sepsis, So that is not end of the story. I need to know which type of organism, whether it is gram positive, whether it is gram negative, whether it is viral, whether it is fungal. So that has to be also getting to like in my mind from this type of biomarker evaluation. Now, if I have got the information also, I started the treatment also, the clinical course has to be also informed by this biomarker, and also prognosis has to be also guided from this biomarker trend. And also I would be getting some of the therapeutic decisions which would be helping me to adapt or utilize or like promote antibiotic stewardship in my ICU. And there would be something which would be characteristic of the biomarker, that should be fast kinetics. It cannot happen like you have sent one biomarker 3 days back and that is positive, 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 and the similar trend is actually getting to know after 5 days also. So it has to be having fast kinetics so that a minute change also in either in the trajectory up or down, that would be also getting to reflect on the biomarker value. Now, it has to be easily detectable via automated and low cost point of care test. This biomarker, as always, we cannot take any biomarker which would not be available to us at the bedside when I need it. And the second point is it cannot be like with the exuberant price. Otherwise, the utility would be very less. And definitely that biomarker will not be appreciated. And rapid turnaround time, the that time has to be really rapid for urgent decision making. So these are some of the ideal features of sepsis biomarkers. Now, the past, present, and future. This is also very interesting to remember. You need to have the etiologic diagnosis, the standardization, rapidity, accuracy, predictiveness, antibiotic resistance, pre-analytical issues. And the age old was the blood culture. You know, there were so many limitations of this blood culture. Now came the serum biomarkers. Serum biomarkers more related to the blood sample also, but yes, recent the biomarkers in a different perspective. So there are certain yes coming in this serum biomarker. But now is the age or era of molecular biology where you will be getting to know about the most important things that are actually previously missing from the blood culture samples. Now, I'm just highlighting with this picture. This is at the left side sepsis, now septic shock, and there is one complication with sepsis, which is one organ dysfunction, that is encephalopathy. Now you see, here comes the role of PAMPs and DAMPs. We all know that PAMPs and DAMPs. Now, with this, you can see there is role of complex protein systems in the form of acute proteins. There would be rise of the acute phase reactants here that would be activating the complement system, coagulation system. Immune cells also are getting activated here with the polymorphonuclear leukocytes, lymphocytes, monocytes. All these things are right now, macrophages are also activated here. Now, coming to the DAMPs here, damage associated membrane patterns. Here, what is happening here, the damage that has actually been afflicted on the vascular tissues and the neurons and the glial cells, as I am talking about the CNS effect, this is also affecting the tissue, the gut, the endothelial cell, the blood-brain barrier, the microglia, and oligodendrocytes, astrocytes. Clear? As a result, what is happening? There is a plethora of like these cytokines as well as the different the molecules, the cytokines, different like the cells are right now getting released starting from this C3, C4, C5, C5b to 9. This is membrane attack complex, MAC. Then CRP. Then I will be discussing lipopolysaccharide binding protein, prothrombin time, cytokines, chemokines, calprotrin, SUPAR, CD48, HLA-DR, CD14, HMGB, TREM, TNF receptors, procalcitonin here, lactate, Guanulin, citrulline, all these things. I'm not going into detail, but these are the biomarkers that can be considered. And as a result, what is happening? Organ dysfunction and failure. So apart from this encephalopathy, it is also affecting other organs. That would be definitely, we have to know all these things earlier so that the patient will not land up in the organ dysfunction and failure. Now, what are the categories of biomarkers? So biomarkers can be categorized on the basis of where actually is the prime, the effect as well as action that is happening. So if I will be starting from the right side, it comes from the acute phase proteins, pro-inflammatory cytokines, infectious organisms and related proteins, different receptors that is getting involved, biomarkers of activated neutrophils and monocyte, I have already shown in my last picture. Then finally, biomarkers for the organ dysfunction and anti-inflammatory markers. So if you remember this terminology, so you can actually make one like this type of picture, and that would be almost self-explanatory. By this, you don't need to write or make tables or like anything that would be taking time on the real exam. Now, I would be now showing you something which would be maybe repetitive, but just to know that yes, this is something I have talked about acute phase proteins. So in that CRP, procalcitonin, serum amyloid A, and that would be indicating inflammatory response during the infection. Now, pro-inflammatory cytokines, we have already discussed the inflammatory cytokines. IL-6 is the bright example, and that would be signaling the immune response to the infection. Activated immune cell marker CD64, that would be reflecting activation of neutrophils and monocytes. Now, the organism related proteins, that would be related to the bacteria, virus and fungi, and that would be differentiating the type of infection, whether it is bacterial, viral and fungal, and also distinguishing local infection from the sepsis. Now, anti-inflammatory markers, where there will be pro-inflammatory, there would be also anti-inflammatory. We do not know in which arm actually we are right now in, whether it is anti-inflammatory arm or pro-inflammatory, whether my patient is going into immunosuppression. So IL-10, TGF-beta, SPDL1, HLA-DR, and that is reflecting body's counter-regulation against inflammation. Now, if I am getting these anti-inflammatory markers at some point of my assessment, so my target would not be right now depressing the immunity level. Rather, I need to augment the immunity level. So that would be the utility of getting this type of biomarker. Now, there would be also some organ dysfunction indicators, biomarkers for organ damage, and that would be reflecting that, yes, now sepsis is affecting that specific organ. So one bright example is sepsis associated encephalopathy that I have shown already, and also SAKI, sepsis associated AKI, acute kidney injury, so on and so forth. And there would be some emerging biomarkers like rapid diagnostic markers alternative to blood culture, and that would be providing quicker and more specific sepsis diagnosis. Now, in one table, if you want to get most important sepsis biomarker, so this is that CRP, PCT. I will be explaining little bit about each one because we all know this is one class where you should be clearing your doubts rather than only related to the exam. Though we always try to explain in very concise manner, but sometimes we feel that this is the one occasion where you will be getting to know about the collection of the literature that we have made. So you will not get time to read all the articles or the important things because it would be time consuming. So whatever I have gone through in my the research or whatever I have done for taking the class or understanding, so I have tried to put up in this presentation. Now, CRP, acute phase protein, source is liver, normal concentration is less than 3 mics per ml. Now, we are not going to detail of everything here, but you can see here PCT, serum amyloid associated protein, IL-6, IL-8, CD64 and lactate. Now moving further, organ dysfunction biomarkers. I'm just showing you the classification of organ dysfunction biomarker. You name the biomarkers, we all know two, three at least the biomarkers associated with SAKI, kidney injury, NGAL, KIM1, cystatin C, then LFABP, which is urinary liver type fatty acid binding protein, and pink A. Why I am going into little detail about each one? Because cystatin C and N-gal was asked in the last time. So I am not going into detail, but I am trying to show you that yes, there are this type of biomarkers also. They can ask you about organ dysfunction biomarker as a whole. Now, cardiac dysfunction, NT-proBNP, TROP-I, TROP-T, high sensitive, TROP-T, TROP-I. Then brain damage is 100, calcium binding protein B, neuron specific, enolase, NFL, glial fibrillary acidic protein, and tau protein. Now, coming to the endothelial dysfunction, then these are the things which would be more thrombomodulin, VCAM, ICAM, ESM. Now, there was a question, I think I remember 4 years back, there was a question biomarkers associated with ARDS. That was completely new at that time. So people were having a lot of problem what to write. Now, surfactant proteins are actually biomarkers, SPA, SPD, receptors for advanced glycation end products, RAGE, Clara cell secretory protein CC16, MMP8, which people have written. There are 2-3 people whom I discussed with, so they have written about this MMP8 hyaluronan surfactant protein. So if you remember, at least you can expand your answer just like here and there. But if you do not know, so it would be completely maybe blank and will not be very impressive to score marks. Now, coagulation abnormality, the prothrombin time D-dimer, that we all know. FDP, plasminogen activator inhibitor 1, thrombomodulin. And there are some general markers of multi-organ dysfunction. We all know lactate, high mobility group box 1, HMG-B1, CRP, and procalcitonin. So if you do not know anything, just write these things also, because that is a general marker of the multi-organ dysfunction. Now, I'm not going into detail. This is something which you can make. I tried to make one more classification, diagnostic marker. Now, in the diagnostic marker, it is ADM, ESM, PI1, S100B, NT-proBNP, BNP, and RNAs, different RNAs. Not going to detail, just remember CD64, TREM1, and some of the newer ones like the different RNAs which are coming up. And this is more for the cancer cells and neural cells. Now, two important biomarkers which we normally use it in our clinical practice is CRP and procalcitonin. So I am trying to explain in detail related to CRP. CRP is an acute phase protein synthesized in the liver in response to cytokines, particularly IL-6. So your IL-6 is actually activating and releasing the CRP from the liver. Now, the kinetics, it increases within 4 to 6 hours of the inflammatory stimulus. Peaks at 36 to 50 hours, and half-life of CRP is almost 20 hours. The key feature, which is actually very important also, this is not influenced by immunosuppression, renal failure, or cirrhosis, contrary to the procalcitonin. Procalcitonin, for that, your patient should be having good immunity to boost up, to show the rise in the procalcitonin. And also renal failure will be also one of the confounding factor for analyzing the procalcitonin elevation. But CRP is not influenced by immunosuppression, renal failure, or cirrhosis. Role in sepsis prediction. They say that maximum daily CRP increase if it is more than 4.1 milligram per deciliter, that predicts ICU acquired sepsis. And CRP kinetics, that is the slope, that is actually outperform procalcitonin in predicting ventilator associated pneumonia. There are certain literatures they have shown that procalcitonin is actually inferior to CRP kinetics in predicting that this patient is going for the VAP. Limitations, they do not, all the guidelines do not recommend biomarkers for like CRP procalcitonin for diagnosis part. And the sensitivity specificity is almost around 78%, 60%. Cutoff value vary between 2 to 10. And comparison, CRP outperforms PCT in distinguish sepsis from non-septic SARS as shown in the CAPTAIN study. Now, this is something CRP ratio. They have mentioned that if you get the response, whether it is fast response, slow response, non-response, or biphasic response, so you can say that my patient is going in the right direction or not. But yeah, we are not using in that way. And there are certain fallacies with the CRPs, but as per the literature, you can do CRP by day 4. And if it is like the ratio is actually dropping down less than zero point 0.4, so it would be fast response. And the clinical relevance is fast or slow responders are actually the better outcomes. So non-response or biphasic patterns indicate therapy failure or complications. At least you will get some idea that yes, I need to change the antibiotic or I need to continue with the antibiotic. Now, CRP guided antibiotic therapy. So in the biomarker section, they may ask you what is the utility of the biomarker at the bedside. So you can always write any of the biomarker, mainly CRP and procalcitonin, that I can utilize procalcitonin or CRP to guide my antibiotic therapy at the bedside. Now, CRP is non-inferior to procalcitonin for guiding antibiotic duration, and biomarker-based strategies reduce antibiotic duration safety. Now, coming to the procalcitonin, what is procalcitonin? That is itself a separate question. I'm not going into detail, but it's a pro-hormone of the calcitonin. We all know calcitonin is secreted by the thyroid C cells, but here it is released from the liver and produced by various organs and macrophages during the inflammation. And the kinetics of procalcitonin increases 3 to 4 hours after inflammatory stimulus, peaks are 24 hours, and half-life of procalcitonin is 22 to 35 hours. There are certain limitations of procalcitonin. I have already explained. Levels are affected by the GFR. So renal patients, your procalcitonin will take long time to get reduced. Renal replacement therapy also, it is one of the factor that would be affecting your procalcitonin kinetics. Now, low diagnostic utility in VAP and viral infection. So if your patient is having CAP with influenza, you will not be having correct the procalcitonin level. Diagnostic utility, sensitivity, specificity, slight more than the CRP. Cutoff range is 0.5 to 2 microgram per liter for sepsis diagnosis. And insights are elevated in also sometimes non-infectious inflammatory states like trauma. So that is also one of the confounding factor, and it is superior to CRP in sepsis suspicion, but not definitive for guiding antibiotics. And we all know the pro rata trial in the antibiotic stewardship, it would be like if you are getting the procalcitonin correctly, so you can reduce the antibiotic usage in your ICU. So I'm not going into detail, but once you are getting procalcitonin as a whole in your exam, maybe it will not be prudent to write everything in the biomarker in sepsis question, but if they are asking specific question, procalcitonin in antibiotic stewardship, so maybe you have to write little bit in detail. And that's why I tried to make it the purpose, the key outcomes of the study was to certain antibiotic duration and how you are going to discontinue the antibiotics if your procalcitonin level is less than 0.5 microgram per liter, or if you are getting the maximum before and now it is decreasing by more than 80% from the peak. So definitely you should think about discontinuing your antibiotic. And how to monitor the therapy response, the timeline, measure the procalcitonin level on day 3 to 4 of antibiotic therapy. It's not that mandatory to do it on every day. So today you have done, so it should be at least 2 to 3 days or maximum as per the literature 3 to 4 days. High levels on day 4 indicate infection control failure and need for aggressive diagnostic or therapeutic measures. Challenges and recommendation, avoid using procalcitonin as a standalone diagnostic or therapeutic tool, and you have to combine with your clinical assessment and other biomarkers like CRP. There would be also high alert PCT. What is that? More than equal to 1 nanogram per ml without more than 10% daily decrease may lead to unnecessary prolonged antibiotic use. You need to think about if you are not getting the patient to be critically sick and the level is also not very high, so you should be thinking to stop it. And these are the difference between C-reactive protein and procalcitonin. I'm not going to detail, but some of the important things. There are possible confounders with procalcitonin. Frequent false negative with steroids, immunosuppression, neutropenia. So I have told you, if the patient is actually immunosuppressed, there would be like no, the rise is not actually evident in the procalcitonin. But CR-reactive protein, it is not there. So it can be a like very interesting question if somebody asks you. So there are no effects on these 4, 5 things you can see. But here in procalcitonin section, you see frequent false negative, false negative, false negative. In renal failure, it will be rising. So if your patient is with CKD or high urea creatinine, so anyway you are going to have a little bit of raised procalcitonin compared to the CRP. And renal replacement therapy, your procalcitonin therapy level would be actually reduced, but that is actually false low, I would say. And then secondary infection is almost similar, and bacterial versus viral, still there is poor correlation. Source is liver, and procalcitonin in virtually all cells and macrophage. Look at the difference. C-reactive protein, it would be only produced from or released from the liver, but procalcitonin from the all cells and macrophage. And it takes less time to go to the peak, 3 to 4 hours. Here, C-reactive protein, 4 to 6 hours. So this is the difference. Now I'm just showing you the normal more important the biomarkers. Not going into detail. IL-6 is one of the things. High levels indicate sepsis severity. High mobility group box 1. Again, this is something related to the if you are getting high, predicts prolonged ICU stay, and clinical use is prognostic biomarker for sepsis outcome and ICU duration. Just remember the names. If they ask you a very long question, 10-mark question, biomarkers in sepsis, you can just write down the names maybe and then try to explain. More or less, the clinical use and significance is almost similar to the CRP and procalcitonin. This is pancreatic. Assigner cells are actually releasing this pancreatic stone protein. Pre-sepsis, sepsin, that is also, it is a soluble form of CD14 on the monocytes and macrophage. And the significance is it is elevated in gram-negative sepsis, and it guides antibiotic therapy and predict patient outcomes. But there is still no universally accepted threshold. Pre-sepsin. CD464, CD full form is cluster of differentiation, expressed on various macrophages, neutrophils, and monocyte, and again high diagnostic accuracy for early sepsis detection. Area under curve is 0.94, and elevated levels indicate sepsis even before clinical symptoms. So this is one of the biomarker which would be guiding you to start antibiotic or have a close eye before the real sepsis symptom signs and other biomarkers start rising. And this is superior to procalcitonin and CRP in predicting 28-day mortality. This is STREM1, soluble triggering receptor expressed on myeloid cells 1. This is surface of neutrophils and monocytes. Significance elevated in bacterial infection, and it distinguishes sepsis from non-infectious inflammation and guides the antibiotic therapy. Now, at the last, there are certain novel biomarkers for sepsis, circular RNA, a tip microRNA, not going into detail. And this is one article which I have also discussed about the prognostic biomarkers. Till now, what I have shown you are the diagnostic biomarker. Now, in the prognostic biomarker, again, just for your understanding and just like one look at the slide, pentraxin 3 is one of the prognostic biomarker. Adrenomedulin, ADM, is one of the prognostic biomarker released by the vascular smooth muscles and endothelial cells. Now, ESM1, that is endothelial cell specific molecule 1, again secreted by the endothelial cells during inflammation. PAI1, that is plasminogen activator inhibitor 1, and that is again comparing or predicting DIC and MODS in the sepsis patients. So this is something more related to the pediatric sepsis risk. And S100B, this is more for the CNS, septic encephalopathy, marker of the blood-brain barrier disruption. Now, only one biomarker, two biomarker as are not very much relevant in clinical practice. Rather, there would be a time or we need to have a multi-biomarker approach in the sepsis management because we do not know which pathophysiologic mechanism is actually more relevant in this patient. So in that, when the sepsis is involving diverse pathophysiologic mechanism, so if we are only relying upon a single biomarker, that will not be capturing the entire disease spectrum. So that's why our multi-biomarker approach, that is a new concept that would be reflecting immune response will be one pathway, inflammation would be the other one, and organ dysfunction would be the third one. So we need to have a battery of tests, and the example would be if we will be having all the three things or four things like PCT, lactate, CRP, and IL-10, TNF alpha, super, and ESM1. So definitely that would be guiding us for the all the pathways or pathophysiology mechanism that sepsis can involve. Now, key points for future perspective. There would be some question also in our Viva also that do you think biomarkers are right now the holy grail, and if you are getting it, it will be solving all our problems at the bedside? No, because there are many challenges with biomarker panels also. There is not a single biomarker which have consistently outperformed individual like the clinical decisions as well as one or two biomarkers due to false positive as well as false negative. And the interpretation also is very important. It's not only getting the report, but how you are actually interpreting, then that would be also influencing the accuracy and utility. Now, it's not only biomarker, it has to be also combined with the clinical algorithm. If we are having an algorithm where the clinical interventions decisions are actually combined with the biomarkers elevation or the depression or like the declining trend, that would be more useful rather than getting the numbers from the biomarker panel. Now that is the second point, and the third point is we are still not very sure that the SARS positive, SARS negative, sepsis definition is also not very clear till date. So only depending upon the biomarkers in real time clinical utility is a questionable thing. Maybe the future would be we'll be getting some advanced algorithms, machine learning and AI would be guiding us if we are feeding the clinical picture and the biomarker panel. Maybe that would be guiding us for more improved diagnostic accuracy and personalization. And hopefully we'll get some rapid testing at the bedside, which will not be like a high turnaround time. Now, just for the last slide, as I have shown you that if your biomarker can be incorporated in the algorithm where our clinical decisions are also very relevant, so that would be something procalcitonin and SOFA score, how we are actually combining together. Can you see here? You are getting the infection suspecting, your SOFA score is rising and the patient is in shock. Then you are sending the culture and you are starting the appropriate antibiotic therapy. You are getting the CRP and the procalcitonin level baseline here. Now you are daily evaluating or re-evaluating your patient. Now after 3 to 5 full days of antibiotic therapy, you are again looking at the clinical picture and calculating the SOFA score. Now if your the SOFA score and clinical picture are both in the correct way, you are thinking to stop the antibiotic. If your procalcitonin is also decreasing more than 80 to 90%, and your CRP decreases more than 50%. And in the meantime, if you are going for like almost 7 days, full day of antibiotic therapy, regardless of the biomarker, you can stop your antibiotic. But if you are still having some or other diagnostic dilemma, you are still not getting extremely the clear picture what is happening, how my antibiotic are actually affecting or clearing the source problem. Persistent focus of infection is there, multi-drug resistant bacteria, overlapping nosocomial infection, then maybe if you are thinking yes the patient is stable, then only stop the antibiotic after 7 days, or else you have to monitor and continue your antibiotics. Not I am going into detail. So final conclusion for the biomarker section. I know it is something you have got to know about so many rare names, but you never know. The examiners are right now going for like the recent advances, and in the recent advances, they may ask you something which you will be more for like this biomarker section. So we need to know that biomarkers can be utilized to predict the response to therapy and prognosis. Each biomarker has its pros and cons. Biomarkers are not holy grails, they are the corroborative evidence. Use biomarkers judiciously, and it has to be a dynamic decision and contextual rather than like somebody has written it, some report has come, so you have to continue with that. And ideal biomarkers must be focused towards detection, identification, monitoring, and orient your duration of the treatment. Any questions at this point of time? Or else I will go to the immunomodulation, which would be shorter duration. Did you find some information from these biomarkers? If you get a question related to biomarkers in sepsis at least, are you in the stage to write it at least to get 80% marks? Anything anybody wants to share? Or else I will go for the okay. Okay. So the next question, again, very important. This is something in the recent advances or in the sepsis. Okay, somebody has posted. Yeah, thank you. Just don't be confused. I have given you so much of information. I know also. So if I will be a student listening to somebody's talk, so I would be also not very keen on how to like memorize all the things and write. But the idea is, if you listen to 100%, you retain 60%. If you listen to 40%, you will be only retaining 10 to 20%. So just have a framework. If you are getting a question related to biomarkers in sepsis, I'm just highlighting how you will be writing. So you will be starting with what is a biomarker, 1 or 2 line. Then why biomarkers are needed in the sepsis management in current scenario. That will be the second one I have shown you in the first slide. Now, what are the types of biomarkers that would be useful in the sepsis? Prognostic, diagnostic, theranostic biomarkers. What would be each utility that you are writing? Then you can show one picture where it would be like the PAMPs, DAMPs, and what are the various types of biomarkers. I have shown you in the picture. That's the circular thing that I have shown you. So you have to show that there, yes, these are the types of biomarkers that can be used in the sepsis, and you have to extrapolate each one. So just maybe you can write about the names, but emphasize on maybe 4 or 5 biomarkers, which are actually everybody knows it. CRP, procalcitonin, then some of the IL-6, TNF alpha, and some of the other super stream 1, CD64, something like that. So what will happen if you write these things and then you give one picture how you are actually integrating biomarkers at the bedside for clinical decisions. So in that you can utilize CRP as well as procalcitonin. Everybody knows about the trials, 1 or 2 trials that has shown that if you are depending upon procalcitonin to use it in your antibiotic stewardship, you can actually reduce the antibiotic free days, increase the antibiotic free days. So that you can mention, and at the end always write about the limitations of the biomarkers and some of the future directions that the biomarkers are taking you. So you can write about personalized therapy, and the time will be coming when you will be getting multiple biomarker panel, and that would be something which would be available at the bedside, and that would be helping you to go for personalized therapy. So you can always frame your answer if you know about these things. So yeah. So there is a question, what is the role of procalcitonin? Yeah, procalcitonin definitely because we are sometimes confused no whether to start antibiotics or not. So procalcitonin for that particular local pathology, that whether it is infected or non-infected, that would be easy to guess. But in pancreatitis, if the patient is having the sterile the pancreatitis, that would not be easy to know. But yes, the patient may be having VAP also simultaneously. Patient may be having central line for some other purpose. Urinary tract infection can happen. So procalcitonin, if it will be rising, so that you can only get to know that yes, this patient is having some or other sepsis, but that is localized to the pancreatic area, that will be difficult to know. That would be only by doing the CT scan guided FNAC and sending the local specimen. Okay, and antibiotics, people always say that no, if your procalcitonin is normal or like no high, then if you have to like no tailor made your antibiotics. But you are not only targeting the pancreas. So that is a counter part. The opponents would be always saying that you are not only highlighting about the pancreas. I will be also taking care of the pneumonia part if the patient is on ventilator, or taking care of the UTI or bloodstream infection or some skin soft tissue infection with the antibiotic. Okay, so hopefully we'll be going to the second question, immunomodulators in sepsis. Again, this can come in the sepsis section as well as in the recent advances section. Now, we'll be discussing in these headings, what do you mean by sepsis induced immune response? What is the role of immunomodulators in sepsis? What are the mechanisms of like these immunomodulators in the sepsis management? What are the types of immunomodulators? What is the evidence behind it? What are the challenges and future directions? That would be the outlines of my presentation. Now, whenever we are talking about immunomodulation sepsis, I would be starting with a very blank statement that is it hope or more of hype? It is a burning question. Always you have seen there are many things that have come. You are also using, I am also using out of desperation. But we do not know whether my patient is getting better with that therapy or not. So simple answer, if somebody will be asking you why you are using immunomodulation, so definitely the answer is yes, there is a like no rational behind using the immunomodulation in my sepsis, because sepsis is actually having immunopathophysiciology. So definitely anything that will be modulating the immunity level or the immune response would be useful. So that is the rationale is actually right. But bigger question is what works. If I am starting it, which one should be started? There are actually plethora, or I would say like no, the armamentarium is big. So what should be at the bedside, which should be used as a holy grail? Now, steroids out of all the immunomodulators, if somebody is asking which is the most widely used immunomodulator, so everybody knows it is steroid, and that has the largest body of evidence. Now, what, when, and where to use these repurposed drugs are still unanswered question. We are using it because we do not have any other magic bullet. So that's why we sometimes think that yes, this is a situation where like no, if you have to take risk, then take risk at that same time. Now, though the consolidated rates of evidence of the benefit of the therapy are yet to be established, the risk benefit ratio is definitely you have to take into consideration. You should not harm the patient further if your patient is in that stage where immune suppression is the problem. So if you are actually targeting for the pro-inflammation or the anti-inflammatory therapies at that time, definitely your patient is going into persistent immunosuppression, and that you do not want. You need to boost up the immunity level at that time. Now, various immunomodulators are being used as off-label with variable success to blunt the hyperinflammation. So if somebody is asking what is the evidence behind it, I also don't know, you also don't know, the researchers also don't know. There is no called science, and definitely you need to think about risk versus benefit or effect versus benefit. That has to be decided. Now, one picture definitely I need to show you that this is the on the left side is the controlled infection. So there is actually the infection is happening, the pathogen is entering, and the pathogen is right now getting cleared by the our body macrophages, the first hand responder, the second hand responders, and finally there is immune homeostasis here happening. Okay. So you can see here from this blood circulation, neutrophils are coming, these pathogens are here in the tissue, then there is macrophages are also here, and somehow all these things are actually right now clearing up this pathogen. Now, but there is a situation where this is not happening, and there is the pathogens are creating more havoc. And you can see, despite your the monocyte, the neutrophil, the macrophages, and the DAMPs and the PAMPs that is happening here, the inflammatory cytokines are actually right now above the level, normal level, and that is the reason why you are getting immune dysregulation. Clear? So this is the problem here on the left side. Now, this is the different types of immune response. If somebody will be asking me before going into the immunomodulator therapy, I need to also know that in which stage my patient is in. What is the immune response my patient is mounting upon? And what is the phase of immune response my patient is in? So if you see here, this is the normal person. He is surrounded by so many pre-sepsis factors, comorbidity, age, genetics, epigenetics, immune status is almost hovering around the baseline. Clear? On the left side. Now you think about the immune homeostasis starts to right now here deflect from this baseline, maybe due to hyperinflammation on the top level, and you can see release of pro-inflammatory mediators. There would be some or other pyroptosis, apoptosis, necrosis, endothelial injury, extravasation may happen, coagulation and complement activation happens. There would be some or other loss of the barriers, anatomical, physiological will happen, and immunothrombosis will happen. So this is the phase of hyperinflammation. Here is the phase of hyperinflammation. Now coming to the bottom one, this is the other extreme end where your patient is in immunosuppression. That means the pro-inflammatory mediators are not the problem. It is the anti-inflammatory immune cells which are actually taking the upper edge. And the T cells, B cells are actually getting exhausted. So these are some cells which would be trying to save you from the intruder to your body. But now there would be actually this is exhaustion of the B cells and T cell happening because of the apoptosis. Rather, there would be some or other anti-inflammatory immune cells will be upregulated like PD1, PDL1 axis. Reprogramming of the antigen presenting cells, APC, reduced HLA-DR expression, and there would be expansion of the TREG cells that I have shown you, as well as the MDSC, which are the mesenchymal cells. So if you will be trying to understand here the phase of sepsis as per the immune response, it would be hyperinflammation and hypoinflammation in the form of immunosuppression. Now, after a few days, when you are targeting with your antibiotics, with your immunomodulators, this patient would be trying to come to the pre-sepsis status. And this is the post-sepsis. You can see here, post-sepsis stage, where the immunity level is almost reaching to the baseline, just like the pre-sepsis. But if you are not targeting your therapy to boost up the immunity, definitely there would be a stage which would be named as post-sepsis syndrome or PICS, post-intensive care syndrome, secondary infections, chronic critical illness, and long-term death. So maybe this patient will be in this range rather than going to the baseline. Before going into the immunomodulator therapy, this is very recent article, Critical Care 2023. I've got to analyze this, and it is so beautifully explaining what is pre-sepsis, what is post-sepsis, and what is sepsis as such, as a whole. And the magnitude of immune response is also here being clearly shown. So if you can just make this type of picture in your exam paper and trying to explain the immunomodulators, I don't think you have to write lot of theory. Rather, it is self-explanatory. Now, there are certain challenges with the conventional therapies in sepsis. Whatever we are using, antibiotic, source control, fluid resuscitation, because the sepsis is heterogeneous and there is a broad classification. Patients with diverse infections, organ dysfunctions, we are actually clubbing together. We are grouping under a generalized diagnosis, it is sepsis. But we do not know the phenotype of sepsis, which would be having a specific patient subset. So that would be limiting the effectiveness of our treatment. if you are actually not tailoring to the specific patient subset. Now, what will be happening if we are doing the clinical trials also based on that therapy, we are not getting the precise therapeutic targets. And that's the reason why for last 50 years or 40 years, whatever trial we are actually going for, it is having trial failures. So that is the point number one. At this stage, we need to have some or other newer immunomodulators rather than the same age-old therapies. Now, we are completely depending upon in critical care on supportive measures. We are only targeting maintain the systemic perfusion, try to eradicate the infections, but we are not adequately addressing the immune dysregulation that is actually driving the sepsis pathophysiology. And that is the problem. So we need to have some or other extra care rather than the supportive care. Now, the third one would be we need to think beyond our conventional therapy. We need to look at to like into the individual immune status, the pathogen specific responses that is happening, and also we need to have the final bottom line immune modulation to restore the homeostasis. Clear? So this is the reason why we need immunomodulators. Now, what is immunomodulator? The next question would be immunomodulator, or it is also named as or known as biologic response modifier, is a substance that enhances or suppresses immune response. It will not be always enhancing or suppressing because we do not know. As I have shown you, hyperinflammation, hypoinflammation, there are two arms. So you need to act accordingly whether your patient is in the top portion or in the bottom portion. Now, the final aim of immunomodulator is to restore immune balance. If there is excessive inflammation, it would be mitigating. And if it is like immunosuppression, it would be also boosting of the immunity level. And finally, it should improve the patient outcome. And it must target various aspects of the immune response I have already explained, but that has to be based on the precise timing. If you do not know that my patient is in the hyperinflammatory arm and I am trying to target the anti-inflammatory, so you are actually hitting at the wrong time. The same thing would be if my patient is in the immunosuppression phase, but I am trying to the also suppressing the immunity level further with hyperinflammatory arms treatment. So we are actually making the patient more weaker. So the therapy has to be tailored based on the individual patient immunoprofile. Now, these are some of the mechanisms. If somebody will be asking, just remember the lines, the first lines, mechanism of sepsis-induced immunosuppression. So I have already explained. There would be the cell apoptosis, significant loss of various cells, T cell, B cell, dendritic cell. Treg cell would be the regulatory T cell, which is also named as Treg. Treg, heightened Treg activity suppressing the immune response. There would be PD1, PDL1. PD full form is programmed cell death pathway. And there would be upregulation of these things that would be leading to cellular exhaustion. That means you just remember that if you are activating cell death pathway, your normal protective cells are also getting destroyed or exhausted. So that would be impairing the ability to respond to the pathogens. Clear? Now, immunomodulatory therapeutic targets would be the second one. In that, it would be actually activating or that would be promoting the T cell function, the proliferation of NK cells, natural killer cells, GM-CSF, G-CSF, interferon gamma, and there would be also immune checkpoint inhibitors. There would be many things which would be blocking the inhibitory pathway. So it would be restoring the T cell function by blocking the inhibitory pathway. Now, the third point would be to immunostimulate something. And the best example is GM-CSF. That remember, like in pancytopenia, if you are having leukopenia, what you are giving? GM-CSF. You are actually stimulating. So that is the same fundamental here, which would be also immunostimulating the macrophage and neutrophil activity through GM-CSF and G-CSF. So these are some of the basic things. Now, the types, you can remember the terminology. targeting specific pathways by biologics. There would be the second one, checkpoint inhibitors or cytokine therapy. There would be mesenchymal stem cells. Everywhere these stem cells are right now entering. So here also stem cells would be there. These are the cellular therapy. And finally, nanotechnology based intervention, which are the upcoming thing. Nanoparticles would be improving antibiotic delivery, that would be countering the drug resistance, and that can modulate the inflammatory response. I'm giving you a picture. So these are the types of immunomodulatory agents in sepsis. Just remember, das ka dam. One, immunoglobulin. Second, MSC. Third, CSF, colony stimulating factor. Fourth, complement inhibitors. Five, JAK inhibitor, which is also named as Janus kinase. Six, PD inhibitors. Seven, TLR agonist, antagonist. TLR is toll-like receptor. 8, monoclonal antibody. 9, cytokine modulators. 10, age old, whatever we are using, corticosteroid, which is having the maximum evidence. So if you remember these things, you can at least write 3, 4 names and the mechanism with which this would act. Okay, so I'm giving you a clue of this thing. And the nanotechnology that I have shown you, nanotechnology is the upcoming thing. So it would be delivering medications in a better way that would regulate the inflammatory signals, that would be utilizing the various diverse materials for managing septic shock, and that would be also utilized as vaccines for sepsis in the future. And also it would improve the diagnostic accuracy in the sepsis. Now, the other way of dividing, I have shown you this picture, Daskadam. Now, again, one other type of remembering the immunomodulators would be selective immunomodulator, non-selective immunomodulators. Third one is the immune augmentation strategy. Selective immunomodulators would be more for the different cytokines, chemokines, anti-TNF alpha, IL-1 receptor antagonist, IL-6 inhibitors, complement inhibition in the form of anti-C5a. Now, non-selective immunomodulator that we are using, corticosteroids, and there is one antibiotic with anti-inflammatory property. Remember, macrolide is one antibiotic which is having immunomodulator activity also. This can be an MCQ for you. Now, immune augmentation strategy, it would be augmentation. Just remember, I have told you GM-CSF, interferon gamma, thymosin alpha, that some of the pharmacology company have promoted also. We have used also thymosin alpha, IVIG, MSC, mesenchymal stem cells, and immune checkpoint inhibitors. Now, I am again dividing into another type of immunomodulators, which would be targeting the inflammation stage. If it is hyperinflammation in sepsis, the trials in the last 5 years, vitamin C, we all have used this Marix protocol, hydrocortisone, vitamin C, thiamine, clarithromycin. Remember the most important things, thrombomodulins, cytokine adsorption, the renal replacement, extracorporeal therapy, coupled plasma filtration and adsorption. That can also help in the immunomodulation by taking out the cytokines. And we all know this extracorporeal blood purification therapy. And the final one is therapeutic plasma exchange. By this, you are actually eliminating the pro-inflammatory and replacing the protective molecules. Though nothing has yet shown clear mortality difference, but yes, the SOFA scores, the organ recovery rate that have been shown to be improving, and your the vasopressor requirements and something related to the hemodynamics would be definitely improving with many of the trials, though it is still not very clear or robust. Now, the other type which you can also mention in your answer is immunosuppression in sepsis. One is hyperinflammation, second one is immunosuppression. In the immunosuppression already discussed, GM-CSF, interferon gamma, thymosin alpha, MSC, immunoglobulin, which is IgM, and also immune checkpoint inhibitor, that is the PD-1 monoclonal antibody, anti-programmed cell death antibody. Now, there are certain strategies to reduce the cytokine storm, which is again one form of hyperinflammation, glucocorticoid, cytokine antagonist, illustratin. Again, you remember, try to keep everything in your answer. So though it has not been showing clear cut like no survival benefit or like no clear cut evidence to support our things. But yes, it would be reducing the cytokine storms with balancing the pro and anti-inflammatory responses, and finally blood purification. So these are the strategies to reduce the cytokine storm. Now there are certain drugs to enhance the innate immunity. Already explained. GMCSF. Just look at my way of presenting. You can write down all these things with different headings. The types in a one format, then other type in another format. Hyperinflammation, immunosuppression pathway, augmenting the adaptive immunity, something like that. And the third one is targeting immune checkpoint. There are four things you have to just remember, and the 10 things that I have told what to remember if you are talking about immuno modulators. This is one slide, like a picture I got, and this is very interesting. Just look at this picture. This patient is right now into the sepsis, early sepsis, and we are completely relying upon antibiotics and catecholamines, organ support, and thinking about that this patient is improving with our normal like critical care support. Now, based on the lab finding biomarkers, we are thinking here whether this patient is in the cytokine storm or no cytokine storm. Now, if it is in the cytokine storms, we need to go for anti-cytokine storm. The therapies that would be reducing the cytokine storm or the hyperinflammation. Now, there is no cytokine storm. You don't need to give any immunotherapy, and you have to just go for continuous immunosurveillance. So for this, there is a concept which is right now coming up, immunometer or immunoscore. That means we need to have a score, just like SOFA score, just like no any other score that we are actually going for our patients, where we will be getting to know that which stage or which arm of the immune response my patient is in right now in my ICU, whether he is in the hyperinflammatory stage or in the immunosuppressed stage. So based on that, I would be thinking whether to go for some of the drugs to enhance the immune function, or I would be going for some of the drugs which would be actually suppressing the immunity level because the patient is in the hyperinflammatory stage. So this is early stage, this is late stage, and you are adding the basic treatment to the immunotherapy. Till now, we are only doing the basic treatment. But if you are getting some or other immunoscores as well as some or other biomarkers which would be guiding us in which arm we are, we can add the immunotherapy with the basic treatment. This is published in the Frontiers in Pharmacology, July 2021. Now, future directions, definitely we need to monitor our patient for the immunoscores and evaluate it continuously. We need to integrate the therapeutic strategy with our whatever we are doing, age-old practice, fluid replacement, organ support, organ perfusion to be better, along with the timely immunomodulatory intervention. And we need to have some other biomarkers which will be guiding us to select our therapy and monitor our therapy at the right time. So that would be completely not only dependent on the clinical manifestation. And the day is not like no far away when we will be having personalized immunotherapy. So you can at the end also can conclude with if my patient is into like all these omics, transcriptome, proteomics, immunophenotyping, metabolomics, lipidomics. So I would be getting subphenotype A, subphenotype B, subphenotype C, and then rather than just like giving a blanket therapy to all my patients in sepsis, I will be choosing for subphenotype A, therapy A, subphenotype B, therapy B, subphenotype C, therapy C. So that would be more evidence based, and that would be also treating the exact trait in which my patient is in. So way forward, definitely the timing has to be good. We still do not know at what stage my patient is in. If I'm starting, whether I am doing right thing or wrong thing, there are still evidence gap in our like preclinical studies as well as clinical trials. And definitely the integrated approach has to be there rather than a one single magic bullet will come and that will cure all our problems. So just with this, the practice point at the last slide, we all know this has a physiologic rationale. We all understand why immunomodulators have a role, but we must understand when, what, and how to use, which we do not know. Judicious use, individualized and personalized, and be in a dynamic mode. Don't be like no fixed with your ideas that yes, I have used that immunomodulator in that patient and I got the benefit, so I have to use that immunomodulator for all patients. No, it cannot be happening like that. Individual therapies targeting phenotypes, endpoints have to be relooked. We cannot always look at the mortality level or mortality numbers. It is not the endpoint for sepsis at least. Further studies to expand our knowledge on the novel indications. Finally, absence of evidence is not equal to evidence of absence. So if you are still not getting the evidence, that doesn't mean that you should not use it. And RCTs has to be decoupled now. So you cannot always think about that, yes, I should be only getting the RCT results and then only I will be starting to use. The observational case series, case reports are also will be helpful in selected patients. And are we desiring too much? If we are right now talking about immunomodulators, we should not be excited. Rather, we should understand the immunopathophysiology and use it judiciously. Thank you very much. I know the explanations and the chapters are actually something which would be little bit of brainstorming. So that's why I have taken a little bit extra time. Yeah. Any questions at this point of time, or else Darshan or Srihari, anything you want to add? Dr. Niharika?
No, sir. I think your talk was very elaborate, sir.
Yeah. I thought these are something very recent advances. So if you will be targeting only with 5-7 slides, people will not be getting the idea, so their concept have to be clear before going for the answers. Yeah. Okay,
True, sir.
so who would be the next one?
Srihari sir will be the next one, sir.
Which one? Sorry.
Srihari sir, Dr. Srihari sir.
Okay, Dr. Srihari. Yeah, Dr. Srihari, the stage is
Yes,
all
sir.
yours.
Yes, sir. I'll take over, sir. Thank you, sir. Is the screen visible, sir?
Yes, it is visible.
Okay.
Please go ahead.
Okay. Okay. Good evening to all. So I have three topics for discussion today. One is on CRBSA, one is Cauti, and the last one is antimicrobial stewardship. So all three topics are important from theory, practical, and real life uh, experience. So we'll go into the topic proper. So first topic for discussion will be on catheter-related bloodstream infections. So I'll be discussing on the definitions and differences between CRBSA and Crbsi, the pathophysiology and microbiology, risk factors, clinical manifestations, diagnosis, complications, differentials, treatment, and prevention. So coming to the differences and definitions between CRBSA and Crbsi. So the first thing related to CRBSA is CRBSA are bloodstream infections where the organism identified in peripheral blood is also present in the tip of catheter or in a blood sample drawn through the catheter. So it is the term which is used by the Infectious Disease Society of America, that is the IDSA. So this definition is commonly used in clinical practice and it requires evidence of catheter involvement with the same organism present in the peripheral blood. So that is the most important criterion. So this PRBC includes all types of catheters, that is peripheral venous catheter, peripheral arterial catheter, CVC, pulmonary artery catheters, PICC line, long-term indwelling catheters like Hickman, Brovia catheters, or implantable devices. Whereas Crbsi, that is central line associated bloodstream infections, are defined as recovery of a pathogen from a blood culture. That is a single blood culture for an organism not commonly present in skin, or two or more positive blood cultures for skin commensals, like staph. In a patient who had a central line at the time of infection or within 48 hours before development of infection. So that is the most important point to be noted. With no other source of infection except the catheter, plus evidence of microbial growth on suspected catheter is not required. So the main thing is presence of fever, then presence of indwelling catheter in the last 24 hours, and no other infection should be present, and microbial growth is not required. So that if all these features are satisfied, then that comes under the definition of Crbsi. So this is used by the CDC. So it's more of a surveillance definition that is used for public reporting, and it is restricted to patients only with central lines, that is central venous catheters. The problem is this definition leads to overestimation of bloodstream infection incidence caused by catheter infections, especially in ICU and hemato-oncological patients. So coming to the pathophysiology, this is a very famous diagram that is taken from Paul Marino. So there are 4 routes through which CRBC can occur. So one is through the infusate contamination, that is supposed to be one among the rarest, whereby it is suspected in otherwise low risk patients receiving IV solutions with uncommon gram-negative bacteria. So administration of contaminated infusate or additives like bread products or contaminated heparin flush or improper aseptic precautions that have been undertaken while administration of drugs, all these can be a potent source of infection. The second is intraluminal contamination. That is contamination of the internal lumen of the vascular catheters that can occur through breakpoints in the infusion system. That is the catheter hubs. That is this site. So this is to be suspected in patients who have a long-term indwelling catheters, especially like tunnel dialysis catheters or Hickman-Brovier catheters. On those kind of catheters should be suspected for these kind of a pathogenesis. The next is the most commonest is the skin colonization. So the microbes on the skin can migrate along the subcutaneous tract of an indwelling catheter and eventually reach and colonize the intravascular portion of the catheter. So this is one which we all would definitely be having in our minds. The most common commensals are Staph aureus and coagulase negative staph. So the deposition of the biofilm on the external and internal surface of the vascular catheter plays an important role in colonization. And the last route is the hematogenous seeding. So microorganisms in the circulatory blood, especially in infections of the GI tract, can attach to the intravascular portion of the indwelling catheter, whereby there can be recurrent bacteremia from the catheter. Sorry, recurrent bacteremia from the catheter may be difficult to distinguish from worsening of a primary focus of infection. So removal of the catheter may help in distinguishing between these two possibilities. So coming to the microbiology, the common organisms which are associated with CRBC are coagulase negative staph, Staph aureus, Enterococcus, Candida species, Klebsiella species, E. coli, Enterobacter, and Pseudomonas. In special populations, the special consideration should be made. In burns, the most common is Pseudomonas. In hematological patients, it is gram-negative bacteria, which is commonly associated with translocation of the gut bacteria. In hemodialysis patients, it's mostly gram-positive bacteria. And in infusate contamination, like with IV fluids, it is most commonly gram-negative bacteria. And with use of TPN, it is Candida parasilosis, which is most common implicated. So risk factors, you can divide it into the two parts. The first one is the host factors. One is chronic illnesses like CKD, CLD, or patients with COPD, or patients with bone marrow transplant, immune deficiency, especially in neutropenic patients, malnutrition, TPN administration, previous bloodstream infections, extremes of age, loss of skin integrity like in burns. All these patients are considered at risk of CRBSA. And you have catheter-related factors, that is duration of catheterization. The longer the duration, the increase the risk. The type of catheter material that is used, the condition of insertion, whether it was done on an emergency basis or an elective basis, because the aseptic precautions used would be very poor in an emergency basis. The catheter site care, the skill of the catheter inserter, whether multiple pricks were done, so that by increasing the risk of infections, the site of infection, insertion, the highest risk of infections are usually associated with femoral because of possible soiling, submaximal barrier precautions, and use of multiple lumens versus single lumen. So the clinical manifestations in most scenarios are usually non-specific, but certain factors that are in favoring of CRBSA are inflammation, pain, purulence at the catheter site, or presence of thrombus that is present, that is usually a complication that is associated with it. These kind of features, if they are there, they go more in favor of CRBSA, but in general manifestations would be fever with or without hemodynamic instability or presence of an altered mental status that can be associated with fever or sepsis itself. So the only catheter site features catheter site inflammatory features that are present may be depictive of a possible infection, but otherwise the rest of the factors are all generalized. So you have to think on a wider spectrum and then come to a diagnosis. So if clinical signs of sepsis start abruptly after catheter infusion, there's medication infusion, a high suspicion of infusate contamination should be considered, and it should be confirmed with concordant growth of pathogen from the infusate and cultures of percutaneously obtained blood. So that would be one way of identifying an infusate contamination. So the lab tests are very non-specific. You can have leukocytosis, high CRP, elevated procal, and blood cultures need to be done to isolate the source and the organism. So you have uncomplicated catheter infection and complicated catheter infection. So the important thing, what we need to know is about complicated because that has a lot of clinical implications. So complicated catheter infection consists of these factors. One is hemodynamic instability, neutropenia, that is ANC less than 500, immunosuppression, and local exit site signs like cellulitis, redness, or purulent discharge. So if any of these four are present, then the features of complicated catheter infection is there. So coming to the diagnosis, you have this is something that I had come up with. It's called the 15, 3, and 2 rule. So we'll go into it subsequently. So the diagnosis of CRBSA should be suspected in patients with fever, chills, and/or hypertension in the setting of a catheter placed at least 48 hours prior to the development of symptoms. So first method is semi-quantitative culture of the catheter tip. That is, the distal 5 centimeters of the catheter is severed and sent for cultures. So the diagnostic criteria for CRBC is same organism on the catheter tip and in the blood culture, peripheral blood has shown the growth. Plus, the growth from the catheter tip has more than 15 colony forming units in 24 hours. So this is the important thing, 15. So the issue with this is it detects only the outer surface of the catheter, not the inner surface, which is a potential source of colonization from the catheter hub. So the second one is differential quantitative blood cultures. That is, you're taking cultures from the central venous catheter and from the peripheral blood. So it has a good diagnostic accuracy, almost 94%. So the same organism is isolated in both in catheter and the peripheral blood. And the colony count from the catheter blood is more than or equal to 3 times greater than the colony count from the peripheral blood. The only concern is it does not detect organisms on the outer surface of the catheter. And the last one is the differential time to positivity, which is the one which we commonly see in our micro lab reports. But they say that the diagnostic accuracy is supposed to be the least of the three. So the same organism in the peripheral blood and catheter blood is isolated, and the onset of growth in the catheter blood is at least 2 hours before the onset of growth in the peripheral blood. So that is the important point that needs to be noted. So 15, because the growth from the catheter is more than 50, has more than 15 colony forming units in 24 hours. 3, because the catheter site blood cultures that were sent has more than 3 colony counts than the peripheral blood. And 2, the time to differential positivity is at least 2 hours before the onset of growth in the peripheral blood. So the differential diagnoses are One is either a primary vascular graft infection. In those who have been operated, have undergone vascular surgeries previously and developed new infections, you need to suspect it. Or mycotic aneurysms, infections of the arterial wall causing development of a new aneurysm, or when pre-existing aneurysms become infected in the setting of bacteremia. So coming to the treatment for Cauti and for Crbsi, if they are asking you about the treatment, you have to mention two things. One is catheter management and antimicrobial therapy. So you can with regard to any kind of an ICU related disease, when you're asked the treatment, you mention general measures, specific measures. So general measures is your fast Hbot, so that you would definitely know. What specific would be to the disease process. So with related to Cauti and Crbsi, it's common. One is catheter management and the second one is antimicrobial therapy. So coming to the catheter management, if you have a suspicion of a catheter related infection, you assess if there is a complicated infection or not. So as I told, the features of complicated infection are shock, neutropenia, immunosuppression, presence of local exit signs like purulent discharge, redness more than 0.5 centimeters of diameter around the site of the catheter, and patients with prosthetic valves or indwelling pacemaker wires. That further increases the risk of CRBSA. So if any of the above are present, you, after the cultures are sent, you started antibiotics and you remove the catheter. Whereas if these features are not there, you go with a watchful strategy and reevaluate after 72 hours. If there is going to be a long-term indwelling catheter, like tunneled catheters or a chemotherapeutic related catheters, like Brovia Hickman catheters, you can try antibiotic lock therapy. That is the same antibiotic that is used systematically. It is given in a concentration of 2 to 5 milligrams per ml in heparinized saline and allowed to dwell in that lumen for 24 hours. So the important thing is during that period, you are not supposed to administer any form of drugs to that line. So once CRBC is confirmed, you assess if it is complicated or uncomplicated. So either case, if it is complicated or uncomplicated, you have to remove the catheter. There is no doubt about it. But if it is complicated, you need to look in for complications, for other complications related to CRBSA, which I'll subsequently discuss. Whereas if it has shown negative microbiology or blood cultures are positive, but it is not related to the catheter, then you go with a watchful waiting strategy. So coming to the antimicrobial therapy, if you have a suspicion of a catheter-related infection plus clinical lab signs of risk factors for complicated catheter infections, you go with empirical therapy. So for gram-positive coverage, you need to cover for MRSA and enterococci. So the first-line therapy is to go with vancomycin. If you have an ICU which has a high prevalence of MRSA and the MIC is more than 2 micrograms per minute, then you need to use daptomycin. And in addition to gram positive, you need to give gram negative also. So that is based on the local antimicrobial susceptibility plus the severity of the disease. So the drugs you can consider are either piptas, cefepime if pseudo prevalence is high, or a carbapenem. And they say you can add a aminoglycoside if there is a multi-drug resistance prevalence being high. And the indications for empirical antifungals are either if they have a femoral catheter which has been there for long term, if the patient is on TPN, hematology malignancies, prolonged antibiotic use, or a recent transplant. If any of these are there and the patient is having a complicated infection, then you can go ahead with the empirical antifungals. So they recommended is to go with echinocandidates, either Anidula fungan, Casper fungan, or Mica fungan. But you also need to assess if there are any organ dysfunctions. Because if there is going to be liver injury associated, then usually Casper fungan is not a good choice. You need to go with Anidula fungan. So fluconazole can be used in the following settings. That is, there is no prior azole exposure in the last 3 months. There are a healthcare setting where the incidence of Crbsi and glabrata is very low. In those kind of settings, you can initiate on fluconazole, but in most settings, especially in Indian setup, we usually go with echinocandins in the first line because the patients who usually develop a complicated catheter infection are really sick. So we don't want to waste time. So if hemodynamic instability, all these features are there and these risk factors are there, usually in those settings, they usually start on echinocandins immediately. So coming to the complications, the first important complication is septic thrombophlebitis. That is venous thrombosis associated with inflammation in the setting of bacteremia. It needs to be suspected in patients with CRBSA with persistent bacteremia. So that is the main point to be noted. So even after 48 hours of, 72 hours of appropriate therapy, if the patient persists to have features of sepsis, then with no resolution of symptoms, then you need to suspect septic thrombophlebitis. So the diagnosis would be to go with a duplex ultrasound and reassess for cultures if needed. So the treatment is antibiotics, anticoagulation if it is complicated, and surgery if it is persistent despite all the above measures. The next is infective endocarditis, that is infection of one or more heart valves. It's suspected in patients with CRBSA or bacteremia more than 48 to 72 hours with pathogen associated with IE. And metastatic musculoskeletal infections manifesting as septic arthritis, osteomyelitis, or orthopedic hardware infections. It should be suspected in the setting of new onset musculoskeletal pain. So any patient who has a complicated CRBSA and cultures have turned positive, along with catheter removal, you need to look into these three complications. So treatment of specific pathogens. So if it is staph, you need to see if it is MSSA or MRSA. If it is MSSA, the preferred is to go with nafcillin or oxacillin. The alternative would be to go with either cefazolin or vancomycin. It is based on the culture and sensitivity. Then if it is MRSA, your preferred initial agent will be to continue with vancomycin, which you might have put as an empirical treatment. The alternative treatment would be to go with daptomycin or linezolid. In cases where there is enterococci present, you need to assess whether it is AMP sensitive, AMP resistant but vanco sensitive, and AMP and vanc resistant. If it is AMP sensitive, then you can go with ampicillin alone. Whereas if there is a penicillin allergy which is present, then you can consider vancomycin. Or if there is a previous penicillin intolerance, then you can consider vancomycin also. So the second agent would be second scenario would be AMP resistant but vancomycin sensitive. So in that scenario, vancomycin is the preferred agent, obviously. Whereas alternatives where vancomycin is not available or there are some issues with the use of vancomycin, then you will have to consider daptomycin or linezolid. Whereas if both of these are resistant, you need to go with dapto or linezolid. Whereas if you have to go with an alternative agent, you need to consider quinupristin, dalfopristin combination. So this is the usual protocol that usually followed. So for gram-negative bacteria, for Acinetobacter, if it is not crab, you can go with carbapenems. But the alternative therapy would be to consider ampicillin sulbactam. Whereas for E. coli and Klebsiella, the initial preferred is carbapenem, but you will have to look at the sensitivity picture and then decide on that. So if that is if there is any abnormalities, you can if there's no any resistance patterns, then the alternative you can consider is Astrianum. For Enterobacter, the preferred agent is carbapenem because it is an escape organism. And alternative agent that can be considered is cefepime. For Pseudomonas, either piptaz or cefepime or carbapenem can be considered, provided the sensitivity pattern is like favors these drugs. Plus, for Pseudomonas, they also say if there it is any drug resistance picture is there, to preferably add aminoglycoside also. So the common one that they say is to go with amikacin. Alternative to amikacin would be to go with tobramycin. For candidemia related to CRBSA, echinocandins are preferred. And the preferred ones are caspafungan and andilofungan. And like I said, fluconazole if the patients are susceptible to it. If there is candidemia and it is sensitive, then you can consider fluconazole. The alternative agents that can be used are liposomal amphotericin B. So the duration of treatment is for 10 to 14 days for bacteremia. For candidemia, it is continued for 14 days after the first negative blood culture. So one of the most important things to note is about the prevention bundles, because from practical perspective, in the afternoon stations in infection control, invariably you will be asked about the infection bundles related to Crbsi, Cauti, and WAP. So you need to know about it. For a CVC checklist bundle, hand hygiene, good compliance is must. Use of maximum barrier precautions during insertion, including full drape. Use of 0.5%, preferably 2% chlorhexidine in skin preparation for disinfecting or cleaning skin before insertion. Catheter site selection. In an ICU patients, it's preferable to avoid femoral route and use ultrasound guidance and decrease the number of pricks. Daily inspection of catheter site. Immediate change of unstuck, soiled, or moistened catheter dressings. And removal of catheter as soon as no longer needed. Another important practice is scrub the hub with 70% isopropyl alcohol. So this is about CRBSA. The next one I would go into is Cauti. So for Cauti, I'll be discussing about these topics: introduction, definition, microbiology, risk factors, pathogenesis, clinical features, diagnosis, treatment, complications, and prevention. So coming to the introduction, urethral catheters are common in critically ill patients. Now, surveys indicate Cauti accounts for 40% of all hospital-acquired infections in the US. However, majority of the catheter-associated infections represent asymptomatic bacteriuria and do not require antimicrobial therapy. So this is a very important point I wanted to emphasize on. So coming to the definitions, because of the presence of bacteria in the urinary sample, it may represent contamination of bacteria colonizing the periurethral area or the bladder bacteria. So thresholds for bacterial growth from a urine sample that is likely to represent a true bladder bacteria in specific contexts has been suggested by the IDSA. So for asymptomatic bacteria, they say culture growth of more than 10 power 5 colony forming units per ml of uropathogenic bacteria should be there in the absence of symptoms, like compatible with UTA in a patient with an indwelling catheter or a suprapubic catheter or an intermittent catheterization within the last 48 hours. So that is the important things to be considered when you are making a diagnosis of asymptomatic bacteria. Whereas for catheter-associated UTA, patients with the clinical signs of symptomatic UTA, that is bacteremia with same organism isolated in blood and urine, any evidence of new onset costovertebral tenderness or suprapubic tenderness, rigors, new onset delirium or depressed consciousness with a urine culture growth more than 10 power 3 colony forming units. If all these are there, without any other identifiable source in a patient with an indwelling urethral, suprapubic, or intermittent catheterization, you can go ahead with a diagnosis of Cauti. So one important thing I want to make a note of is in asymptomatic bacteria, the cutoff is 10 power 5, whereas for Cauti, it is 10 power 3. So that needs to be noted. Another important thing that needs to be noted is the following findings are not reliable for the diagnosis of Cauti. Just presence of fever or leukocytosis alone is not sufficient, because in an ICU patient, you have a wide spectrum of differentials you have to consider. Presence of cloudy urine again is not reliable for the diagnosis of Cauti, and presence of WBCs in urine or presence of pus in urine. That is the most important thing. It does not differentiate between asymptomatic bacteria and Cauti. But if that is negative, you can confidently rule out Cauti. So coming to the microbiology, the most common organisms implicated in Cauti are E. coli, Candida, Enterococcus, Pseudomonas, and Klebsiella. So most of them are gram-negative organisms, and others that can be possible are coagulase-negative staph aureus, and Acinetobacter. So the risk factors are modifiable factors and modifiable factors. So these include duration of catheterization. As I said, the longer the duration, the increase the risk. Non-adherence to aseptic catheter care, low professional training of inserter, catheter insertion that is done outside of the operating room, and catheter insertion that is done after the sixth day of hospitalization. All these have been associated with an increased risk of Cauti. And non-modifiable risk factors are female sex, severe underlying illness, that is high Apache score, then non-surgical disease, age more than 50, diabetes mellitus, and patients with a serum creatinine more than 2 milligrams per deciliter. So in these subset groups, it has been associated with an increased risk of Cauti. So coming to the pathogenesis, so UTIs associated with catheterization can be either extraluminal or intraluminal. So extraluminal is more common, attributes to two-thirds, that is 66%, and it occurs via entry of bacteria into the bladder along the biofilm that is usually monomicrobial, though polymicrobial can occur. So it forms around the catheter in the urethra. Whereas for intraluminal infections, it accounts for 34% of the cases. It occurs due to urinary stasis, due to drainage failure, or due to contamination of the urine collection bag with ascending infection. So once it reaches the bladder, the bacterial adherence increases via adhesin molecules. That is the ability of the pathogen organisms to adhere to the bladder epithelium, leading to lower urinary tract infections. So this is one of the most simplest ways of putting up the pathogenesis. So the clinical features specific to Cauti would be suprapubic, flank, or costovertebral tenderness, but the rest of the features are again non-specific: fever, altered sensorium, lethargy. And lab findings are again, as I mentioned, very non-specific: leukocytosis, raised inflammatory markers like CRP, and urinary is highly unreliable in diagnosis of Cauti. Pyuria can be present or cloudy urine will be present, but that does not mean that the patient has Cauti. You need to look at the clinical picture as a whole and then make a call. So the diagnosis, Cauti being uncommon, in the presence of fever that is new onset, other causes need to be ruled out first. Even though in the initial introduction that I mentioned, they said that 40% cases have been reported to be Cauti. In our setting, it is not so. You have other infection sources which are more common than Cauti. So Cauti has to be suspected at the last line of your differentials. Look for localizing signs. Assess for suprapubic or costovertebral tenderness. If it is negative, routine testing for UTA is not advised. But in the current era, that is like in our now current era where focus is available easily, you can assess the bladder and the kidneys and assess for any evidence of infection and then make a call on your diagnosis. So in patients with a short-term catheter that is less than 30 days, the urine specimen for culture can be obtained by sampling through the catheter tubing. So if it is a asymptomatic bacteria, that like I said, there is not much of clinical features, but the urine count shows more than 10 per 5 colony forming units, then that comes under asymptomatic bacteria. So it should not be screened further except for research purposes, or it should be considered significant in pregnant women. Whereas for CAR-T, it is defined as urine cultures that grow more than 10 power 3 colony forming units in patients with clinical signs of symptomatic UTI. So for patients with a long-term catheters, that is more than 30 days, the catheters need to be replaced first and then you send the specimens for collection. In the setting of a condom catheter, it can be difficult to distinguish CAR-T from skin and mucosal contaminants. In these cases, a clean catch midstream specimen is needed, but there are a lot of logistic issues that need to be considered. It's very difficult to be sampling in these cases. So, like I said, for CAR-T diagnosis, you need to be making based on the clinical picture as a whole. You need to assess for certain renal signs and bladder signs, and you can also use an ultrasound and then make your diagnosis. So the complications are bacteremia, which can lead to sepsis, and involvement of the upper urinary tract. So the prevention is avoid insertion of indwelling urinary catheters, placement only for appropriate indications. Early removal of indwelling catheters, that is use of a checklist or a daily reminder. Consider alternatives to indwelling catheterization, that is intermittent catheterization or a condom catheter, and use proper techniques for insertion or maintenance, that is sterile insertion. Secure the catheter to prevent movement and keep it below the level of the catheter. Maintain a closed drainage system. Avoid routine bladder irrigation. This is one thing which we routinely do. If there is an obstructed bladder, we immediately try to irrigate the bladder with saline. That is supposed to be a bad practice. And we need to maintain a unobstructed urinary flow. So that is also another thing which needs to be looked into. So one thing I wanted to emphasize is this Houdini checklist. Now, as I mentioned in this previous slide, for early removal of indwelling catheter, you can use a checklist or a daily reminder. For that, we can use this Houdini process. So each letter has a meaning. So H is for hematuria. If O is obstruction or catheterized by urologist, U is urological surgeries, abdominal gynec surgery or perineal surgeries. D is decubitus ulcer. I is input and output measurement. N is nursing end of life care patients. I is immobility, bedbound or uncommunicative. If all or no, then you can remove the catheter. If not, you will have to you can mention the reason so that there is a proper handover. So that is the one checklist that can be kept in mind, the Houdini checklist. So coming to the treatment, like I said, for either CRBC or Cauti, you can go with either catheter management and you have to go with the antimicrobial therapy. So with catheter management, ideally the catheter should be removed at the earliest, but there may be patients who may need a long-term indwelling catheter, like patients with traumatic brain injury, whereby the sensorium process to be poor. In these set of patients, you need to keep it long-term. So the catheter replacement ideally should be done every 30 days. With regards to the antimicrobial therapy, first I'll discuss about bacterial, then I'll go into candidiuria. So for asymptomatic bacteria, antibiotic treatment is not advised unless the patient is scheduled for urological procedure associated with mucosal bleeding like TOP. Since in these subset of patients, asymptomatic bacteria can progress to Cauti. And in patients with Copti, usually empirical treatment is usually with a single therapy. Either we go with piptas or carbapenem. Because, like I said, the most common organism that you isolate is E. coli. So it is usually sensitive to either of these drugs. And alternative drug that can be considered is levofloxacin. But India being endemic for TB, we don't routinely use it. So the duration of therapy is usually for 10 to 14 days. So with regard to candidiuria, the most commonly isolated is Candida albicans or Candida glabrata. So the presence of Candidal species in urine usually represents colonization in patients with an indwelling urethral catheter. That is in most scenarios, especially in diabetic patients. But Candidiaria can also be a sign of a disseminated candidiasis. That is, Candidiaria being the result of disseminated candidiasis. So that also needs to be kept in mind. So if at all the patient is having a candidiuria and risk factors for candidemia is also present, you need to work up for that. That is, you need to look into those pictures. So in asymptomatic cases, you don't really need to treat it, except if the patient is neutropenic or the patient is immunosuppressed. Whereas if the patient is symptomatic, then the first line drug they say is you can go with fluconazole. But if there is no response or the culture isolate has shown either Glabata, Crbsi or Oris, then you will have to go with amphotericin B deoxycholate. That is the dose they say is 0.3 to 0.6 milligram per kg IV daily. Plus we need to add flucytosine also. So in which scenarios can you consider treating CAR-T in the initial basis itself? Based on the studies that I had read through, you can consider in patients with neurological or neurosurgical diseases, because in those subset of patients, it is difficult to identify the source. Because in those cases, you cannot really elicit for suprapubic tenderness or costovertebral tenderness. So if fever is present with, again, a dip in GCS, which is not neuro-related, and there is presence of feature suggestive of Cauti, then you can treat it as Cauti. But the important thing is you need to rule out other conditions first before you make a diagnosis of Cauti. So that is one thing I wanted to emphasize. So the second talk is over. So then I'll go to the last talk, that is on antimicrobial stewardship. So coming to antimicrobial stewardship, it's a short topic, but it's very important, and it's a very high probability question for the upcoming theory exam. So you need to know about it in depth. So coming to the introduction, so antimicrobial stewardship refers to a systematic assessment of coordinated interventions designed to promote optimal use of antimicrobials by advocating selection of appropriate antimicrobial drug regimens. So what we routinely see is adverse effects related to antimicrobial use is seen in 1/3 of patients. So the adverse events that are seen are emergence of antimicrobial resistance. So they say administration of an antimicrobial course to a patient exposes approximately 10,000, almost 10 power 12 bacteria in that patient to selective pressure, which may alter the intestinal microbiota for almost a year, plus decrease the number of antibiotics available. It increases the risk of C. difficile infection or colonization. So they say the presence of C. difficile infection itself is considered as a surrogate for antimicrobial misuse. Like how they say if the ICU has a lot of cases of Acinetobacter, then they say that the ICU is contaminated. Similarly, if C. difficile infection is present in many patients in that ICU, then they say antimicrobial misuse is very rampant. And drug toxicity. So the goals of antimicrobial stewardship are: one is to decrease antimicrobial resistance. Second is to decrease healthcare costs and to improve patient outcomes and safety outcomes. So what patient outcomes are improved? It has been associated with the reduced length of hospital stay, reduced mortality, reduced need for mechanical ventilation when antibiotics were used appropriately. With use of a patient safety, it has decreased the antibiotic use, decreased the C. diff related colonization and infection, and there had been no increased mortality or admissions in patients who had undergone proper stewardship policies. So, for antimicrobial stewardship program in ICU setting, there are two components. One is optimization of the antimicrobial therapy and avoidance of unnecessary antimicrobial administration. So the first one I'll discuss is about the optimization. So coming to the optimization, we have 4 parts or 4 steps. The step one is making a diagnosis. When you see a patient, or when a patient has been newly admitted to the ICU, you need to look into 4 things. Is it an infection? Rule out non-infectious mimics. Rule out colonizers or contaminants. Take appropriate specimen cultures to be able to confirm eventual diagnosis, and determine whether to start an antibiotic empirically or, if possible, wait till the definitive diagnosis is made. So these 5 things need to be kept in mind in the initial phase. Then for step 2 is empirical antimicrobial therapy. So the important considerations that need to be made is the severity of illness. If a patient has a mild disease, you can go with the narrow spectrum. That is, patients who have been admitted in the ward, they won't be really in that bad shape. So in those cases, you can go with an narrow spectrum, but patients who are admitted in the ICU usually have a high severity of illness. So in those subset, you need to start on a broad spectrum antibiotics, and you will also need to consider adding various coverages like gram negative, gram positive, and plus or minus antifungal also. Then you have to consider whether the likely you'll have to consider the likely pathogen and their anatomical source with consideration of source control based on rapid diagnostic tests and gram stain as appropriate. The likelihood of drug resistance, that is known colonization with a drug-resistant pathogen, recent antimicrobial use, exposure to healthcare facilities, and local resistance patterns. And you assess for host factors. Like immunocompromised patients, you need to give a wider spectrum of coverage. In renal or liver dysfunction, there will increase risk of toxicities. So you need to go with dose adjustments. And you also need to assess for allergies. So it may preclude the use of a particular antimicrobial class. And determine the appropriate dose and the appropriate route. The important thing is in all ICU patients, you need to start with only intravenous route of administration because if at all the patient is shocked, the gastric absorption is going to be a big concern. So it will affect the bioavailability and the tissue level penetration. And initiation of antimicrobial therapy as early as possible. So that is being shown as an important determinant of outcome. Most of you definitely know about it. I'm just emphasizing it here. And adequate dosing based on PKPD considerations. That is maximize tolerable use and use of prolonged infusions whenever possible. And importantly, identify presence of augmented renal clearance. That is creatinine clearance more than 130 ml per minute per meter square because it will affect the duration of the drug because there will be enhanced elimination. And identify presence of increased volume of distribution, like presence of hypoalbuminemia, large volume crystalloid administrations. All these can significantly alter the infection site concentration of the administered antibiotics. So the next step is tailoring the antimicrobial therapy. That is the most important part. That is antimicrobial timeout. So in patients receiving empirical antimicrobial therapy, the regimen should be re-evaluated on a continuing basis as the clinical condition evolves. And as soon as the microbiology results are available, you need to titrate your plan of antibiotics. So it is usually done within 48 to 72 hours. Previously, the blood cultures take 40 to 72 hours. Now, with availability of MALDI-TOF, you get it within 24 hours itself. So based on that, you can titrate your antibiotics. So antimicrobial timeout, in which antimicrobial results are reviewed and my antimicrobial therapy is adjusted from empirical to a definitive antimicrobial therapy because you may have started on a very broad spectrum. You might have added gram negative, gram positive, and antifungals. So based on that, you can once the organism is isolated, you can target that alone. Step 4 is therapeutic drug monitoring. Currently, it has been confined to vancomycin, aminoglycoside, and voriconazole. So they said that use of therapeutic drug monitoring has been associated with decreased nephrotoxicity, reduced length of hospital stay, and reduced mortality. So that is also an important thing to be kept in mind. So the first thing is making a diagnosis. Second, selection of empirical therapy. Third one is tailoring antimicrobial therapy. And fourth one is therapeutic drug monitoring. So the second part of antimicrobial stewardship program is avoidance of unnecessary antibiotic administration. So that is the second part. So before we go into that, we need to know what is antibiotic de-escalation. So it is a clinical approach to empirical antimicrobial therapy of serious infections that attempts to balance the need for appropriate initial therapy with the need to limit unnecessary antimicrobial exposure to curtail the emergence of resistance. So that is about the antimicrobial de-escalation. So how can it be done? One is use of antimicrobial resistance prediction tools that is based on risk factors. Biomarker guided antimicrobial therapy, use of CRP or procalcitonin helps in guiding decisions regarding antimicrobial therapy. As you know, regarding procalcitonin, there are 2 to 3 very good trials that have come out which have shown good outcomes, especially in patients with BAP. Use of rapid microbiological diagnostics, that is use of molecular platforms currently existing for rapid identification of pathogens and antimicrobial susceptibility. So they include multiplex PCR and MALDI-TOF. So MALDI-TOF is matrix assisted light desorption ionization, time of light. And the last one is immunochromatography. So it aids in faster diagnosis and de-escalating the antibiotics within 24 hours. So by that way, you prevent unnecessary exposure to a wide variety of antibiotics compared to conventional microbiological procedures. So you have an antimicrobial stewardship team itself. So like how you have an infection control team, there is an AMSP team itself. So there it consists of a set of people who are involved. The first person would be a physician who is ID trained, that is infectious disease trained, who will be the leader. So he should report the activities and outcomes regularly to the senior executives and hospital board and make changes as needed. So he or she is co-led with a pharmacist leader with ID training. Then that team consists of clinicians and heads of departments. Hospital epidemiologists are a main set of people in the team because they monitor, audit, analyze, and report facility-wide data. Then quality management staff to investigate medical quality and patient safety issues. Then microbiology lab, that is antibiograms to guide empirical therapy. IT staff to integrate stewardship protocols in with existing workflow. Now, medical records are now becoming electronic based. So, addition of these stewardship protocols into your daily assessment management will help in uh, seeing to that these protocols are adequately followed, thereby improving outcomes. And nurses ensure cultures are taken before starting antibiotics. So, like for quality indicators that we know of, we have for stewardship programs also, we have indicators. So you can measure the antibiotic use by assessing the days of therapy. So there are two formulas that you need to know. One is the days of therapy, that is the aggregate sum of days for which any amount of a specific antibiotic is given to a particular patient, and the denominator is standardized, that is usually 7 to 14 days based on the indication. And defined daily dose, that is the aggregate total number of grams of antibiotic administered during a period of time by the standardized regimen designated by WHO. It would be difficult to remember, but at least remember the names. That is days of therapy and daily defined dose. And you have process measures and outcome measures. For process measures, you have excessive days of therapy. That is unnecessary days of therapy based on accepted targets and benchmarks, the duration of treatment, the proportion of patients compliant with facility-based guideline treatment algorithms, proportion of patients with revision of antibiotics based on microbiological data, and proportion of patients who have been converted from IV to oral therapy. So these are the process measures. At least out of five, 2 to 3 remembering for the exam would be good. And outcome measures are hospital length of stay, 30-day mortality, unplanned hospital readmission within 30 days, proportion of patients diagnosed with hospital-acquired C. difficile attributed to antibiotic treatment, and proportion of patients with clinical failure, that is, need to broaden treatment or recurrence of infection. So usually these are the things that need to be looked into for a successful stewardship program. So the overview, so whatever I've told, and from a practical perspective, what I'm going to show you will be very helpful. So you have a suspected infection in ICU patients. First, you obtain microbiological sampling for culture and special stains, biomarkers, and rapid diagnostic testings. You prescribe empiric antibiotics, employing a combination of agent targeting like multi-drug resistant organisms based on local epidemiology and patient risk factors. Now, just a small tip. In your practical exams, if at all you get a case like Crbsi, VAP, or Cauti, if they ask you what is your antibiotic of choice, you say, I will start the antibiotics based on the local epidemiology and patient risk factors. So if you start with that line itself, most of the time the examiners will be impressed. So this is just an add-on point because I just went through this. And you monitor the clinical response to treatment. That is temperature, WBC count, hemodynamic parameters, biomarker levels, and organ function. So once you've done a microbiological identification of pathogens and you've assessed the antimicrobial susceptibility, you assess the scenario at 48 to 96 hours of treatment. So if there is if there is significant improvement after 48 to 96 hours, but there is no growth of organisms, then you can consider discontinuing an antibiotic or limiting the course of therapy to just 7 days. I'll just repeat it. So if the antimicrobial identification is negative, the patient is clinically improving, then you consider discontinuation or limiting the course to just 7 days. Whereas you have identified the organism and the patient is also improving, then de-escalate the empirical antimicrobials based on the microbiology results and discontinue the antimicrobials after 7 to 10 days based on the site of infection and pathogens. 7 to 10 days is just mentioned in general, but there are certain organisms like Pseudomonas and all where you need to give it for at least 14 days. Whereas in either of these scenarios, whether your culture has come positive or negative, if they have not improved clinically, then you need to review the dosing of antibiotics to optimize the drug levels, reculture for possible superinfections, and consider non-infectious cause of fever and inflammation. And most importantly, examine for abscess formation if at all you still have a suspicion of infections. Thank you.
Thank you, Srihari.
Okay, ma'am.
Good evening, all. Able to see my slides?
You need to open it, I think so, ma'am. I'm seeing your.
Open just 1 sec. I think now it's visible, Darshan.
Yes, ma'am, it's visible.
Okay, thank you. So good evening, all. So I will be discussing about two important topics. One is the invasive fungal infections, and my second topic would be iris. So invasive fungal infections, I think apart from your theory and practical exams, I think it is a very important topic in day-to-day practice also. So you'll be confused in many of the, for what Candida or aspergillosis, whether we need to treat it, we need not to treat it. So today, I think most of your questions will be answered. So the outline of my topic would be introduction, the general risk factors for all the fungal infections in the ICU, some definitions, and we'll be discussing about the three important fungi, the Candida, the Aspergillus, and the Mucor. And some important points on IDSA guidance 2016 discussing the Candida and the Aspergillus. Now, coming to the previous year questions, recently two questions has been asked in our DRNB exams. In 2024, you had this rhino-orbital cerebral mucormycosis, the diagnosis and management. And in December 2022, you had the 4-mark question, which is enumerate the risk factors for fungal sepsis in ICU. Now, coming to the introduction, why is this fungal infections a problem? I mean, treatment of this is a problem in the ICU. So first one is the fungi, they generally produce disease only when the immune system of the host is compromised or when the mucosal or the integumental barriers are disrupted. And the second point is fungal cultures, they lack sensitivity as well as specificity in some cases. And in such cases, the diagnosis is dependent on a combination of factors. And when we treat these fungal infections, the antifungals which we use are more toxic to hosts because of the similarity in the metabolic pathways, which these antifungals also follow, which is similar to that of the normal metabolic pathways which the fungi do. Then coming to The other important factor, these fungi form the biofilms on a variety of indwelling devices. So because of these things, treating the fungal infections is very difficult. Now coming to the risk factors. So there are a lot of risk factors. These are general risk factors which I'll be discussing, and later on the specific risk factors for each of the fungi. Okay, so diabetes, any kidney injury or a patient on RRT, if the patient is on parenteral nutrition, patient has acute severe pancreatitis, has high Apache 2 scores, if the patient is on prolonged mechanical ventilation, or a patient has a CBC and urinary catheters for the long time, if the patient is on broad spectrum antibiotics for a longer time, prolonged ICU stay, any major surgery, and burns. These are the general risk factors for any of the fungal infections. Now coming to the contributing factors. One is because of the presence of vast majority of pathogens of fungi. Second, because of the delayed diagnosis, because these they take a longer time for culture results. And nowadays, after the COVID, I think steroid use have been rampant. So concomitant steroid use is one of the contributing factor. Because of the emergence of MDR Candida auris and use of biomarkers have actually made the diagnosis of these diseases more common. Now, before going into the actual topic, we should know some definitions about the antifungal therapy. So this antifungal therapy can be divided into three. One is the prophylactic treatment, one is the empirical treatment, and one is the preemptive treatment. So you should know this both for the practical as well as your theory exams. So this prophylactic treatment is divided into primary prophylaxis and secondary prophylaxis. So what is primary prophylaxis? It is nothing but administration of the antifungal agents to patients who have not had a prior episode of invasive fungal infection, but they are at a risk of developing one now. So that is known as primary prophylaxis. What is secondary prophylaxis? So we administer antifungal to those patients who have already had a prior invasive fungal infection. Okay. Now coming to the empirical treatment. So empirical treatment is administration of the antifungal treatment to febrile patients during a period of neutropenia prior to a confirmed diagnosis of an invasive fungal infections. So neutropenic patients having fever, but still you have sent all the cultures or galactomannan assay or beta-2-glucan everything, but the results are awaited. But since the patient is having fever, you are going to start the treatment, that is empirical treatment. Now coming to preemptive treatment. So if patient has any of the following positive, either clinical or radiological or galactomannan assay positive, then you are going to start the antibiotic, any one, okay? That is known as preemptive treatment. Okay, so these are the definitions. Now we'll go into the individual fungi. So first we will be discussing about the candidiasis. So the most common organisms, I think there are more than 30 to 40 candida species which are present, but most important one which cause the invasive fungal disease are Candida tropicalis, Candida albicans, Parasilosis, Glabrata, Auris, and Cruzi. So this Candida glabrata is actually inherently resistant or has a high resistance to fluconazole and also to other azoles like voriconazole. Whereas Candida cruzi, it is inherently resistant to fluconazole, but it is sensitive to voriconazole. Coming to the predisposing factors, as I mentioned before, the many general risk factors. Additional to that, you have GI perforation, one of the risk factor for Candida. Now coming to the syndromes. So what syndromes do this Candida manifest as? Okay. So the most important or the common thing is the candidemia, okay, which usually manifests as sepsis or septic shock. Okay, it can also manifest as acute disseminated candidiasis in the form of cutaneous manifestations. It can manifest as endovascular infections like infective endocarditis or any infections of the ICDs. Can manifest as osteomyelitis, arthritis, endophthalmitis, and in some cases, it becomes chronic disseminated candidiasis, especially candidiasis of the hepatosplenic region. So these are the different syndromes or manifestations of the candidemia. Now, how to diagnose this? Candidal infections? So there are a lot of diagnostic modalities. So important one is the Candida colonization index. Okay, this is nothing but the number of sites colonized by the Candida divided by the number of body sites which has been surveyed. Okay, score of greater than or equal to 0.5 is considered positive for invasive candidiasis. Second, we have a lot of scoring systems present like Lyon, Ostrowski, Zechner, Shore, and Nebraska. I'll be discussing about the same in the next slide. Now, coming to the blood cultures, they are gold standard, but the sensitivity is very less, 50%, and the specificity is around 75%. Coming to the next one, the beta D glucan levels, okay, which is nothing but a pan-fungal marker. It is mostly positive in both Candida as well as Aspergillus, with a sensitivity and specificity of about 80%. Next comes the molecular adsorption techniques, that is nothing but the MALDI-TOF, so which gives the resistance patterns as quick as 30 minutes to 1 hour, but it requires a positive growth on cultures. So you have sent a culture and it has grown some organism, and you will get the resistance patterns within 30 minutes to 1 hour. And then you have a PNA fish. And the last one is the T2 Candida based assay, which basically uses the MRI detection to differentiate between Candida albicans and Candida glabrata. The last two are rarely used. Now, as I told previously, some scores which are important for the diagnosis of the Candida or invasive candidiasis. So one is the Candida score. Okay, I think everyone calculates its Candida score when the patient is long-term in the ICU. So there are 4 important components. One is the abdominal surgery, sepsis, septic shock, total, if the patient is on total parenteral nutrition, and if there is a multifocal Candida colonization. So the sepsis with septic shock is marked as 2 points. The other 3 is 1 point. If the score is more than 3, then it is suggestive of invasive candidiasis. The sensitivity is around 77.6%, where specificity is around 66. Now, the second one, the Candida colonization index, which I was talking about, also known as Petit score. As I told, if it is more than 0.5, then it is indicative of invasive candidiasis. Then the other score which I mentioned was the Ostrowski-Zechner score, which suggests that if there is a presence of central venous catheter plus greater than any of the 2 of the following, like the patient is a total parenteral nutrition, patient is on hemodialysis, patient has pancreatitis, on corticosteroid therapy or any immunosuppression, then it indicates presence of invasive candidiasis. The sensitivity is around 74% here. And the NMC, that is nothing but the Nebraska Medical Council score, which includes basically 5 components. I think it is similar to the above things. So here, but the sensitivity is around 84.1%. So at least remember 2 scores for the exam. Now, treatment. So treatment, we all know we basically use either azoles or echinocandins in our routine practice. So when to use what is very important. So echinocandins is basically used for moderate to severe illness. So what are the echinocandins? Which we know is Caspo, mica, and the Anodula fungens. So these echinocandins are usually the sidal drugs which are preferred for critically ill or if the patient has a recent azole exposure. And the recent data, a lot of data has shows that it has improved the survival rates in invasive candidiasis. But the disadvantage is that these have a poor penetration into eye, CNS, and urine. So if any patient presents with any CNS infections or a urosepsis or an endophthalmitis, so use of echinocandins is limited. Now coming to the triazoles, which are nothing but the fluconazole and the voriconazole. So these are basically used for mild to moderate illness, and these are basically static drugs. And these drugs actually are the drug of choice for genitourinary candidiasis because they have an excellent urinary concentration. So urosepsis, better to use these. Fungal urosepsis. Then amphotericin B, it is an alternative option to echinocandins in resource-limited settings. And adjuvant therapy, you have to do a source control. If suppose there is a central line, you're going to do remove the central line. And you have to also see if there is any metastatic infections by doing an ophthalmic evaluation, that is the fundoscopy. And you have to do a 2D echo to rule out any infective endocarditis focus. Okay. And what should be the duration of therapy for Candida? It is 14 days of effective antifungal therapy following a negative blood culture and the resolution of illness. Okay. So now recently this Candida auris has become a most popular species in Candida. So a small note on Candida auris. So this has become a serious threat to healthcare settings over the last decade, causing serious invasive fungal infections as well as nosocomial outbreaks. So it ranks second among the critical pathogen in the WHO panel. So now coming to the challenges in this Candida auris, why is it become so, a threatening organism? One is because of its rapid and easy transmission. Second, it's been contaminated very badly in the environment and it is resilient to heat and disinfection. Next, there is a potential for development of antifungal resistance rapidly with this. And also it is accountable for high morbidity and mortality, nearly about 23 to 72%. And also it is difficult to identify by commonly used phenotypic methods which we use for the Candida. I think we have discussed with so many, diagnosis modalities for the usual Candida species, but these are not used to diagnose the Candida auris, and difficult to manage due to resistance to azoles and growing resistance to polyenes. So how do we usually diagnose this Candida? By commercial identification systems. There are a lot of identification systems, which I'm not going to discuss in detail here. I'm just mentioning it. And the other one is the MALDI-TOF and some molecular tests and cultures. But cultures, as we know, it is time consuming. Now, very important is the prevention. So we have to proactively screen for this organism. You have to augment the infection control practices, and you have to educate about the practices, infection control practices to the sisters as well as the doctors. Now, how do you manage this Candida auris? So basically it is divided into three. If there is an invasive disease, how do you manage? If there is an UTI, and if there is a colonizer, so how do you manage? So if it is an invasive disease, then what is the drug of choice for Candida auris? It is nothing but the echinocandins. So in case of absence of clinical response, and if there is a persistent candidemia for greater than 5 days, even on echinocandins, then you switch on to liposomal amphotericin B. You can use azoles only if it is susceptible after doing the susceptible testing. Okay. So the azoles which are used are posaconazole and isavuconazole, because fluconazole and voriconazole are they are inherently resistant to the auris. Now, suppose if the patient presents with Candida auris UTI, so echinocandins except the micafungin may not achieve sepsis. So as I told, echinocandins urinary concentration is less. Micafungin has about around 20 to 30% of urinary concentration, but that will not help us much in the treatment. So we have to basically use a combination therapy for this UTIs. One is echinocandins, plus you can use amphotericin B in this state. And if it is a colonization, CDC does not recommend treating C. auris colonization. That is nothing but isolation of the auris from non-sterile body sites in absence of invasive disease. So no treatment is required for the colonization. So this is how you treat the Candida auris. Now this completes the Candida. Now next, coming to the aspergillosis. So I've just discussed for your 5-mark question. I'm not gone in detail. IDSA guidelines have given only some important recommendations, which I'm going to discuss in the last. Now coming to the aspergillosis. So the most common are the Aspergillus fumigatus, the flavus, Aspergillus niger, and oryzae. So predisposing factors, apart from the risk factors which I mentioned previously, these are the most important risk factors for any invasive aspergillosis. One is if the patient has prolonged or profound neutropenia, if the patient is on prolonged steroids or any immunosuppressants, especially the T-cell immunosuppressants, if the patient had a hematopoietic or a solid organ transplant, patients with primary immunodeficiency states like CGD, or the recent emerging factors for aspergillosis include any patients of COPD, liver cirrhosis, critically ill patient, or patient on long-term mechanical ventilation. So these are the predisposing factors for aspergillosis. So what are the different manifestations or the syndromes which these patients of aspergillosis present? The most common we see is the pulmonary aspergillosis. Okay. The second one is acute rhinosinusitis, especially if the patient has a nasogastric tube for more than 2 weeks. The others are tracheobronchitis in patients of in lung recipient patients or HIV patients, cerebral aspergillosis in patients of diabetes mellitus, which is basically uncontrolled, osteomyelitis, can present as cutaneous aspergillosis and disseminated aspergillosis. Now, diagnosis. Diagnosis is very important. So, we should know about two important things. One is how proven in invasive aspergillosis, and about the probable and possible invasive aspergillosis. Now, coming to the different scores which are used. Okay. So, initially only one score was present, that is nothing but the UORTC MSG score. But recently two more scores has been added. One is the ASP-ICU and the biomarker ASP-ICU. So just names you remember, it's more than enough, but UORTC MSG criteria has to be remembered. Okay. So what is proven IA? When do you tell, yes, this patient has confirmed invasive aspergillosis? If the patient has a positive mycology or histopathology of a sterile sample, which is obtained in a sterile manner. So either histopathology or a culture positivity. Okay. That is known as proven invasive aspergillosis. So now what is probable and possible? So for this, you have three criteria which you have to remember. One is the host criteria, one is the clinical criteria, one is the mycological criteria or the fungal criteria. So what is the host criteria? So patient should be a neutropenic patient, or patient should have hematological malignancies, which are basically the risk factors which I have discussed in the previous slides. Okay, solid organ transplantation, patient is on steroids or any immunosuppressants, or if there is an inherited severe immunodeficiency. So, sorry. So this is the first criterion, the host criterion. Second is the clinical criterion. So what is the clinical criterion, especially when you see the CT? Okay, especially the pulmonary HRCT when you see. So if there is a dense, well circumscribed lesion with or without a halo or a air crescent sign, or if there is a cavity, or if there is a wedge-shaped and segmental or lobar consolidation. If these are present, that is the clinical criterion. Now coming to the mycological criterion, it is nothing but a positive microscopy or culture from a respiratory sample, or galactomannan assay positive, or PCR is positive in bile or blood. Okay. If all the three criteria are present, then it is a probable invasive aspergillosis. But if only two criteria are present, then it is possible invasive aspergillosis. So you have to remember this criterion both in exam as well as for your clinical practice. And if any new criteria they ask about, then you can just mention about the ASP-ICU and biomarkers ASP-ICU. Okay, you need not to go in detail about those. If you are interested, you can just go through later. Now, as I mentioned here, the clinical criterion where you have two signs, the halo sign and the air crescent sign. Okay. So anyone can just tell me what is the halo sign and the air crescent sign? Anyone? No?
Ground glass opacity surrounding a nodule is halo sign, ma'am.
Okay, correct. Ground glass opacity surrounding a
Nodule.
okay, pulmonary nodule. Okay, very good. What does it basically represent? Angio invasion, basically. Okay, angio invasion. So, and what is air crescent sign?
Presence of air between the mass and the cavitation wall.
Okay, and what does that represent?
Ma'am, resolution phase of the
Very
disease.
good, very good. It marks the recovery phase of the infection. Very good, very good. So this is the air crescent sign where you can see air as a crescent shape. And this is the halo sign where you have the ground glassing. There's a pulmonary nodule which is surrounded by the ground glassing. Good. Next, galactomannan assay. I think we use it in many patients. The serum galactomannan, BAL galactomannan. So we should basically know the cutoffs, where to use, where do you get a false positive values. Okay. So galactomannan assay. So what is galactomannan? It is nothing but a polysaccharide antigen that exists primarily in the cell walls of the Aspergillus species. Okay. So it is only specific to Aspergillus. Okay, so it may be released into the blood and other body fluids, even in the early stages of the Aspergillus invasion, and the presence of this antigen can be sustained for 1 to 8 weeks. Okay, so you can actually detect till 8 weeks the galactomannan assay. If you do, it may become positive if the patient has a invasive aspergillosis. So it is basically done by ELISA method. And what are the cutoff values? Important. Serum, the cutoff value is around 0.5, and for BAL, it is 0.7. Now, serum, the sensitivity is around 70% in neutropenics and 20% in non-neutropenics, whereas specificity for both is around 85%. For BAL, the sensitivity is more than 70% in all risk groups, including patients on mold active prophylaxis, and the specificity is around more than 90%. So BAL is better than the serum. Now, what are the limitations? So we should know in which cases this may come as false positive and in which cases this might come as false negative. So false positive, I think the most common which you people might tell that patient, especially if the patient is on medications of fungal origin like piptaz or amoxiclav. And the other thing is if the patient had underwent recently the allogenic hematopoietic stem cell transplantation, or if the sample sometimes had a cotton contamination, or if there is a presence of other fungi like fusarium or penicillium or histoplasma, if they are present, then it may turn as false positive. And if the patient has recently received cyclophosphamide therapy, then it might come as a false positive result. Now, coming to the false negative results. Okay. There is aspergillus is positive, but it has come negative. The test has come negative. If the patient has mold active agents, was presently on any mold active agents, or if the patient has an anti-aspergillus antibodies, if it is a locally invasive infection, and increased frequency of sampling may also lead to false negative results. Okay, so these are the limitations of the galactomannan assay. Now, coming to the treatment of invasive aspergillosis, the drug of choice, as we all know, it is voriconazole. The dose is 6 mg per kg IV BD for day 1, which is followed by 4 mg per kg IV BD. The alternative agents could be amphotericin B liposomal, echinocandins. These are not cidal for aspergillus, just they have a role in salvage therapy, or if the patient is intolerant to amphotericin, or if there is a prior voriconazole prophylaxis has already been taken. In such cases, you can use even echinocandins. Or the recent one, the isavuconazole, can also be used as a salvage therapy. So the dose is around 200 mg Q8 early for 6 doses, then 200 mg OD. So what is the duration of treatment? So it is a very vast duration of treatment, that 6 to 12 weeks. Okay, nearly 1.5 months to 3 months, you might take this antifungal therapy for invasive aspergillosis. I will tell about the guidelines later. Now, coming to the last one, the mucormycosis. This has been recently asked in your exam. So I have discussed in little detail about mucormycosis. So what are the clinical syndromes which is associated with specific risk factors for mucormycosis? So in poorly controlled diabetic mellitus patients, the most common is the rhinocerebellar or sino-orbital or cutaneous mucormycosis. Patients with hematological malignancies or a transplant, that is hematopoietic stem cell transplantation or solid organ transplant patients, the most common presentations are pulmonary, sino-orbital, cutaneous, and disseminated mucormycosis. Also in penetrating trauma and burns, mucor manifestations are more common. And the other risk factors are any chelation therapy with desferoxamine, or patients with IV drug users, endocarditis is more common. In patients with malnutrition or any premature infants, GI mucormycosis is more common. Coming to nosocomial acquisition, which is linked to contaminated dressings, splints for IV cannulation. If it contains or it has been contaminated with mucor, then you might get a cutaneous mucormycosis. And unknown etiology, in some cases, you may even get isolated renal mucormycosis. So basically, mucor involves almost all the organs in the body. Now, as I told, this was asked in your exam recently. So, rhino-orbital cerebral mucormycosis. So, this is the most common presentation of mucor, and this is caused by the Rhizopus oryzae organism. So, basically, this occurs due to inhalation of spores into the paranasal sinuses of a susceptible host. So what is the most important risk factor? Hyperglycemia, usually with an associated metabolic acidosis. That is basically if the patient presents with DKA, then that is the most common risk factors for this rhino-orbital cerebral mucormycosis. So how do these patients usually present with? So usually they present as an acute sinusitis, like the patient might be having fever, nasal congestion, purulent nasal discharge, headache, and some sinus pain and tenderness. They usually present with this. Basically, all the sinuses become involved and they spread to the contiguous structures. So the hallmarks of the spread beyond the sinuses are there could be tissue necrosis of the palate leading to palatal eschars. There could be destruction of turbinates. There could be perinasal swelling, erythema, and cyanosis of facial skin underlying the involved sinuses and or orbit. What are the signs of orbital involvement? If from the sinuses it's moved into the orbit, then there could be a periorbital edema, proptosis, and even blindness. And in most of the cases, there would be a facial numbness because of the infarction of the sensory branch of cranial nerve 5. So the patient may present with all these signs and symptoms if the patient has rhino-orbital cerebral mucormycosis. And as we know, cerebral patients usually present with a decreased sensorium. Now, how do you diagnose the mucor? So basically, it is diagnosed by direct microscopy. So what are the most common stains which are used for mucor? It is the calcofluor white and the methenamine silver. Okay, cultures, yes, but difficult to isolate mucor. Histopathology, basically used to differentiate mucor from other molds, also to document the evidence of angioinvasion, which is very important in case of mucor. And radiology. So radiology, basically in the pulmonary mucormycosis, you will be seeing about the infiltrates, especially the nodular infiltrates. So if there are more than 10 nodular infiltrates, then it is most probably the mucor. And the reverse halo sign as we discussed. So reverse halo sign, which is nothing but if you see here, I'm so sorry. The black arrow, this is nothing but the ground glass opacity, which is surrounded by a dense consolidation. So this is a reverse halo sign. In the other one, we saw the pulmonary nodule followed by the ground glass. So, and the other thing is pleural effusions. Coming to the diagnosis of the rhino-orbital cerebral infection. So how do you diagnose this? One is by the history. So if the patient has high-risk patients, like if the patient has uncontrolled hyperglycemia, plus if there is an evidence of sinusitis or an altered sensorium or an infarcted tissue in the nose or palate, then you think of the diagnosis of the rhino-orbital infection. The other thing is you have to do the FES or the endoscopic evaluation of the sinuses. So you have to look for any tissue necrosis and you need to obtain the specimen from that and you have to send for the microscopy. Then imaging. So why do you do imaging? Imaging is done to gauge the sinus involvement and also to evaluate the contiguous structures which has been spread by this infection, like especially the eye and the brain. And the better one is to do a CT scan because you will be knowing about the bony destruction in the CT scan. Now coming to the treatment of the mucor. So if the sinuses involvement are there or orbital involvement are there, then surgical debridement is the first one, followed by or simultaneously you have to give the antifungal therapy and you have to do the elimination or treatment of the predisposing factors. Okay. So drug of choice for mucor is polyenes, that is nothing but the liposomal amphotericin B. The dose is 5 mg per kg OD. Maximum you can go up to 10 mg per kg per day. Okay, the alternative involves the posaconazole or isavuconazole. So basically, these are only the salvage therapy. Salvage therapies are that the patient is not responding to the present treatment or is actually worsening on the present treatment. So in such cases, you can, that is known as salvage therapy, and you can use either posaconazole or isavuconazole in this case. So coming to the posaconazole, basically it requires 7 to 8 days to achieve the therapeutic concentration, and the absorption is actually maximized when taken with a high fat food. This has to be remembered. Okay. The adjuvant therapy could be desferoxis, then hyperbaric oxygen, then granulocyte stimulating factor, and interferon gamma can also be used. Now coming to the duration of treatment. So until near normalization of the radiographic imaging, or if there is a negative biopsy specimen or culture from the affected site, and recovery from immunosuppressions. Okay, most of the things have to be present. Till then, you need to continue the treatment. So as I told, echinocandins, there was no much role for echinocandins in mucor. They have no in vitro activity, but as I told, the Rhizopus orzea, it actually expresses the target enzyme for echinocandin. So these agents can be tried if none of the above agents have been effective. So you can actually try echinocandins in these cases if you have, isolated this Rhizopus. There is no role of oriconazole, fluconazole, and flucytosine in cases of any mucorale. So this completes the 3 important fungi species. Now coming to the guidelines. So I'll be discussing the guidelines for Candida and Aspergillus. So if you have time, please go through these guidelines, 2016 IDSA guidelines. A lot of pages were there. So only important recommendations I have just put on here for your theory exam. So if you have time, please go through the guidelines in detail. So coming to the Candida. So candidemia in non-neutropenic patients. So how do you treat these patients? So as we already saw that echinocandins are the drug of choice. Okay. If the patient is moderate to severely sick. So the different doses have been mentioned here. So it is recommended as the initial therapy, which has a strong recommendation and high quality evidence. Now coming to the fluconazole, either intravenous or oral. Okay, it is accepted as an alternative to echinocandins as initial therapy in selected patients. Who are those patients? One is those who are not critically ill and who are considered unlikely to have a fluconazole-resistant Candida species. In such cases, you can use fluconazole. Okay, it's a strong recommendation with high-quality evidence. Now coming to the testing of the azole susceptibility. It is recommended for all bloodstream as well as other clinically relevant Candida isolates. So you have to do the azole susceptibility test, especially if the patient has candidemia. Okay. Now testing for echinocandin susceptibility, it should be considered in patients who have had a prior treatment with an echinocandin, and in those who have infection with Candida glabrata or Candida parapsilosis. Okay, in such patients, you need to do a echinocandin susceptibility test, and if it is susceptible, then only give the echinocandin. Okay. Now, what is the role of amphotericin B? So this is a reasonable alternative if there is intolerance or limited availability or resistant to other antifungal agents like echinocandins or triazoles. In such cases, you can even try liposomal amphotericin B. Now coming to oriconazole. So oriconazole 400 mg, it is effective for candidemia, but it offers little advantage over fluconazole as initial therapy. So it is recommended only as a step-down oral therapy for selected cases of candidemia due to Candida Crbsi. Okay. Now, follow-up blood cultures should be performed every day or every other day to establish the time point at which candidemia has been cleared. Because after that, you have to give 2 weeks of treatment and then stop the treatment. So this has a strong recommendation with a low quality evidence. And recommended duration of therapy for candidemia without any obvious metastatic complication. That has to be kept in mind. If there is no metastatic complications, then you have to treat this for 2 weeks after documented clearance of Candida from the bloodstream. And there should be resolution of symptoms which is attributable to candidemia. Okay. So that's why you have to do either daily or alternate day blood cultures. When it is negative, from that day, you give 2 weeks of treatment of antifungals and then you can stop it. But if there is a metastatic complications, then you might even extend it from 2 weeks to 4 to 8 weeks. Okay. Now, this is about the non-neutropenic patients. If the patient is a neutropenic patient, I think the drug of choice here would be an echinocandin. Okay. But if there is any contraindication, then you can try the fluconazole. But the best drug would be an echinocandin. And additionally, you have to give the granulocyte colony stimulating factor. Okay. So it can be considered in cases of persistent candidemia with anticipated protracted neutropenia. Then you can give the granulocyte colony stimulating factors. Now, what in case of candida in the respiratory secretions? If you have the patient is intubated, patient is having candida in the respiratory secretions, would you like to treat this? No. Basically, this indicates the colonization and it rarely requires treatment with antifungal therapy. It is a strong recommendation with moderate quality evidence. Now coming to candiduria. So if there is a asymptomatic candiduria and there is a symptomatic candiduria. So what do you do in these cases? If there is asymptomatic candiduria, so we have to first eliminate the predisposing factors, if any, like if there is an indwelling bladder catheters, then you remove it. That is the first thing that is recommended in asymptomatic candiduria. Treatment with antifungal agents is not recommended unless the patient belongs to a group at risk for dissemination. Like if the patient has a neutropenia, or if this is in babies, very low birth weight infants, or the patient who might undergo urologic manipulation in the next few days. In such cases, you treat with antifungals. Otherwise, you need not to treat asymptomatic candiduria. Just remove the Foley's catheter. That's more than enough. Now, if the patient has a symptomatic candida cystitis, then what to do? Yes, in such cases, you need to treat these patients. As I told, for genitourinary infections, the best agents is the trioles, that is nothing but the fluconazole. So you give fluconazole in such cases. So in fluconazole susceptible organisms, you can give either oral fluconazole daily for 2 weeks is recommended. If there is fluconazole resistant, like Candida glabrata, at such cases, you can use amphotericin B, or you can also use oral flucytosine. Okay. If there is a Candida cruzi now, in such cases, you have to use the same amphotericin deoxycholate can be used. Okay. The duration of treatment for such is 1 to 7 days. So removal of an indwelling bladder catheter, if feasible, is strongly recommended even in symptomatic candida cystitis. And in some cases, they've also told that you can do a bladder irrigation with amphotericin deoxycholate. But it's a weak recommendation and low quality evidence. I think if you do this bladder irrigation, as Dr. Srihari told, there is increased chances of making the infection become bad. So I think this recommendation was there. I don't know now whether it is applicable or not. So I don't think that it should be followed at a present state. So this is how you treat the symptomatic candida cystitis. Now that was about the candida guidelines. Now coming to the aspergillosis guidelines. So what is the role of this galactomannan as well as 1,3-beta-D-glucan for the diagnosis of aspergillosis? So this galactomannan assay, especially the serum and BAL, it is recommended as an accurate marker for the diagnosis of invasive aspergillosis when used in certain patient subpopulations like hematologic malignancy or stem cell transplantation, which is a strong recommendation and a high quality evidence. But routine blood screening in patients receiving mold-active fungal therapy or prophylaxis, this galactomannan assay would not help much. Okay, but you can actually do a BAL specimen if you are suspecting a pulmonary aspergillosis. Okay, serum will not help you much. So you can do BAL in such cases. Okay, and this assay is not recommended for screening in solid organ transplant recipients or patients with any chronic granulomatous diseases. And when you come to 1,beta-D-glucan levels, these are recommended for diagnosing invasive aspergillosis in high-risk patients. Okay, but are not specific for aspergillosis because it can come positive even for the candida. Okay, so better to do a galactomannan assay in patients with high risk, you can do any one. But if you want to do a pulmonary aspergillosis and patient who are already on fungal therapy, better would be to do a BAL galactomannan assay. Now, what is the role of bronchoscopy in the diagnosis of invasive pulmonary aspergillosis? So, there is a recommendation for performing a bronchoscopy with BAL in patients suspected with a suspicion of invasive pulmonary aspergillosis, which is a strong recommendation. The yield of BAL is low for peripheral nodular lesions, so percutaneous or endobronchial lung biopsy should be considered. So, if you see some nodular lesion, okay, only one nodular lesion is there, peripheral nodular lesion. And if you perform BAL in such cases, your galactomannan assay might be negative. Okay. So if you still have a high suspicion, then better to do a percutaneous or endobronchial lung biopsy in such cases. Okay. So use a standardized BAL procedure and send BAL for the routine cultures as well as cytology and non-culture based methods. Now, what type of antifungal agents are used for both the treatment as well as prophylaxis of invasive aspergillosis? So, as we told, aspergillosis, voriconazole is the first drug of choice. It belongs to the triazoles. Okay. So, amphotericin B deoxycholate and its lipid derivatives are appropriate options for initial as well as salvage therapy when voriconazole cannot be administered. If there is any contraindications for voriconazole, then you can use this amphotericin B. Echinocandins are effective in salvage therapy either alone or in combination against aspergillosis, but the IDSA does not recommend their routine use as monotherapy for the primary treatment. So in case of neutropenic patients, I think we have already discussed colony stimulating factors may be considered. Okay, and granulocyte transfusions can be considered for neutropenic patients with aspergillosis that is refractory or unlikely to respond to standard therapy and for an anticipated duration of more than 1 week. So in such cases, you can even do a granulocyte transfusion. So this completes your invasive fungal infections. If you have any doubt, please put it in the chat box. I will answer your questions. Now, next. So this was asked most probably in all the previous FNB exams. I think recently it's not been asked, but it is a potential question. So we'll just discuss about it. Not much of, it's not a big topic, a small topic. So I'll be discussing about what is the definition of iris and what are the types of iris, pathogenesis, how to prevent this, what is the clinical presentation, the diagnosis, and the treatment. Now, what is, so we'll go to the introduction. So the goal of antiretroviral therapy in individuals with HIV is immune reconstitution. But what is the disadvantages of this immune reconstitution? It may produce iris, right? So iris is also known as immune restoration disease, which refers to a disease or a pathogen-specific inflammatory response, which may be triggered after antiretroviral treatment initiation in treatment naive patients or after a change to a more effective ART regime in patients who fail to achieve the viral suppression. So you have started recently an ART or the patient is already on ART who is not responding properly, so have changed the regime, then the patient developed iris. So both can happen. Okay. So this manifestations of iris is divided into two. One is what is paradoxical iris and what is unmasking iris. Paradoxical iris is nothing but worsening of previously diagnosed disease is known as paradoxical iris, whereas appearance of a previously undiagnosed disease is known as unmasking iris. Okay. So these are the two different types of iris. So this iris is usually accompanied by an increase in the CD4 count and or a rapid decrease in the viral load. So patient had a very high viral load initially. His CD4 count was some around 50. You have started the ART, viral load has come down, your CD4 count has increased to more than 200. Then this iris is usually manifested. But not in all the cases. Okay, not all the cases of increase in CD4 count may cause iris. That has to be remembered. Although most cases of iris occurs in patients who have low CD4 counts and high viral loads, especially 50 and the viral load is more than 1 lakh, at the time of ART initiation, it can occur at any CD4 count. Okay. So it usually presents within the first 4 to 8 weeks after ART initiation, but has occurred many weeks later and in sequestered sites such as the bone. So it can occur at any time. There is no fixed time, but most commonly seen in 4 to 8 weeks after initiation of the ART. Now coming to the pathogenesis. So pathogenesis includes two things. So what happens when there is a high antigen load? So high antigen load can occur in patients with low CD4 count, if there is a disseminated opportunistic infection, if there is a positive inflammatory response to opportunistic infection, or short duration or suboptimal treatment of opportunistic infection. In such cases, there is a high antigen load. When this happens, our innate immunity response may lead to excess pro-inflammatory cytokine activity, leading to the symptoms of iris. So in this high antigen load, if you have initiated an ART now, so what happens? Our acquired immune response, okay, will come into action. Okay, so this leads to immune cell dysfunction, leading to the same excess pro-inflammatory cytokines, leading to the symptoms of iris. So the symptoms of iris can be either focal or systemic. Okay, now causes of this immune cell dysfunction could be of various mechanisms. One is because of uncoupling of innate and acquired immunity. Second, there could be restoration of exuberant pathogenic specific cellular immune responses, or there could be any defective or delayed regulatory responses. So because of these, there could be immune cell dysfunction. So all this leads to the symptoms of iris. Now, timing of ART initiation in patients with recent opportunistic infections and the prevention of iris. Okay, so basically you should know when to initiate the ART so that you can reduce the risk of iris. Okay, that is what is meant by this heading. So because ART is the key to the recovery of the immune function, the benefits of early ART initiation should outweigh the risks of iris. Okay. So patients being treated for any of the following active infections, a lot of infections are there. In these patients, you can initiate the ART within 2 weeks of starting the opportunistic infection treatment, or as soon as the patient is clinically stable on opportunistic infection therapy. So within 2 weeks, you can actually initiate. In what of the infections? If the patient has a cryptosporidiosis, microsporidiosis, if the patient has PML, Kaposi sarcoma, PCP pneumonia, HBV or HCV infection, or any other serious bacterial infections. In such cases, you start the treatment for the underlying opportunistic infections, and within 2 weeks or as soon as the patient is stable, you can start the ART. Okay, so the risk of occurring iris in such cases is less. But the optimal timing for ART initiation is not well established for infections like TB meningitis, extrapulmonary TB, CMV retinitis, and cryptococcal meningitis. So here comes the actual problem. So the risk of iris is much more in these infections. Okay. So this is just the thing which I have already told. So pulmonary TB, I think I have not discussed in the previous slide. So pulmonary TB, it depends on the CD4 count. Okay. In case of CD4 count of more than 50 cells, you can initiate the ART as soon as the patient is clinically stable after initiating the TB therapy, but no more than 12 weeks later. So within 12 weeks, we need to initiate the ART therapy if the patient has a pulmonary TB and the CD4 count is more than 50. But if the CD4 count is less than 50, we need to initiate the ART within the first 2 weeks after initiating the TB therapy. Okay, this is about the pulmonary TB. This is important because this is the most common opportunistic infection which we see in our HIV patients. Okay, the other one I think I've already discussed previously. So now coming to the clinical presentations, how do these patients present? So common features are clinical deterioration after ART initiation and localized tissue inflammation with or without a systemic inflammatory response, which I previously discussed in the pathogenesis. So the presentation varies depending on the underlying opportunistic infection or illness. So as I told, it usually occurs within 4 to 8 weeks after initiation of or change in ART. However, there are cases which has been reported as early as 3 days or as late as several months, or rarely in some cases several years after ART initiation. So there is no fixed time. Okay. So the late manifestation of iris, which usually occurs more than 7 months, it may present atypically. Okay, such as it may present as osteomyelitis resulting from Mycobacterium avium complex. Okay, so very atypical presentation of the iris can occur after 7 months of start of ART therapy. So major presentations, the clinical presentations would be the patient might be present as TB, any MAC infections, cryptococcal meningitis, CMV retinitis, hepatitis B or C virus, PML, Kaposi's sarcoma, cerebral toxoplasmosis, histoplasmosis, or a autoimmune disease. And minor presentations could be HSV and BZV, Mpox, non-specific dermatological complications. Okay, these are the minor presentations of the iris. So these are just the tables in which how do they usually present with. Basically, we all know it. Already the patient has an opportunistic infection. There could be worsening of the symptoms. So if it tuberculosis of the brain or tuberculosis of the lung, so it depends on what system and how the manifestations can occur. So I think most of you all will be knowing about these manifestations. So just go through this if you have a time. Otherwise, you can just write in your exam about this, how they present. That's more than enough. You don't have that much time to elaborate all these things. Okay. So these are the minor presentations. I've already discussed all these three. Okay. Now, how to diagnose the iris? So a definitive diagnostic test is not available for iris. So basically the diagnosis is largely based on the clinical judgment, which may be challenged by the broad array of iris signs and symptoms and the presence of multiple opportunistic infections. You can't say whether this is a new opportunistic infection which has come or it is because of the iris the patient has become bad. It is very difficult to diagnose. Okay, a rise in CD4 count is often present in iris cases, but it is not required criterion for diagnosis. Okay, so one of the criteria. So in patients who are not responding favorably to opportunistic infection treatment prior to ART initiation, but who have worsened after the initiation, the differential diagnosis could be, one is your paradoxical iris, or it could be the treatment toxicity of opportunistic infections, or because of the drug resistance, or because of the poor treatment of the opportunistic infections, or development of a new opportunistic infection. So many differential diagnoses are there. So you can't diagnose, yes, this patient has an iris, so difficult to diagnose. So development of a new opportunistic infection after ART initiation may be attributable to unmasking iris or to the effects of persistent immune compromise. So how do you treat iris? Okay, so iris is basically divided, the treatment is basically divided into mild iris and severe iris. So what do you do for mild iris? Basically, you need to reassure the patients. Okay, if the patient is conscious enough, reassure the patient that the worsening of these symptoms could be due to the initiation of the ART and it might resolve spontaneously in the next few days. So first, reassurance is important. Next, in addition to the standard therapy for the underlying opportunistic infection, for example, if the patient had a TB, it was improving, then when you start the ART after around 2 weeks, then the patient had uh, a respiratory difficulty, patient is becoming more tachypneic, desaturated, everything. So in such cases, additional to the treatment of the, I mean, you'll be already started with anti-TB medications. So along with this, you have to have some specific treatments which may alleviate the inflammation. Okay, like you can give NSAIDs for discomfort associated with mild inflammation or fevers, or you can give paracetamol if the patient is having fever. If the patient is having any abscesses, then you have to drain the abscesses. If there is a painful lymph node, then you have to do excision of the lymph nodes. And in cases of bronchospasm or cough, which is associated with mild pulmonary inflammation, in such cases, inhaled steroids can help. So basically, it is a supportive treatment which you can do in cases of mild iris. But if it is a severe iris, what is severe iris? Which may threaten a patient's functional status or it may cause permanent disability. In such cases, you need to treat this iris. Okay, so what is the treatment? It is nothing but the steroid therapy. Okay, steroid therapy, we give it to suppress the inflammatory response. Okay, and what is the dose of steroid in the iris? It is 1 to 2 mg per kg of prednisolone or the equivalent for 1 to 2 weeks, followed by a period of tapered dose that is individualized. So this is what the guidelines recommend. Okay, so this is a treatment for severe iris. Mild iris is supportive treatment. Severe iris, you have to give the steroids additional to your opportunistic infection treatment, which has been worsened. So the risks of steroid therapy should be outweighed against the severity of the iris manifestations and the potential benefits, particularly given the high prevalence of type 2 diabetes, hypertension, and mental health disorders among the patients with HIV. Okay, these are the patients who usually, HIV patients may have all these, and when you give steroids, this might worsen the underlying conditions also. So I think you know the risks of corticosteroid therapy. There could be hyperglycemia, hypertension, mental status changes, avascular necrosis, worsening of an existing infection, and predisposition to a new infection. Okay, so we have to weigh basically the risks and benefits of the steroids in such cases. And basically, these steroids are contraindicated in cryptococcal meningitis or in patients with Kaposi sarcoma. So even though if the patient has a severe iris in such cases, you should not give the steroids, just treat the underlying disease or the opportunistic infection. That is more than enough. Otherwise, this might actually worsen the opportunistic infection further. And in any case, ART should not be interrupted in patients with iris except in life-threatening cases, which is nothing but if the patient has a CNS iris or in which corticosteroids did not result in improvement. In such cases, only you need to stop the ART. Otherwise, please continue the ART. Need not to stop in iris. Okay. Thank you.
Thank you, ma'am. I think so. There was a question about dual antifungal therapy, ma'am.
You carry on with Darshan. I'll answer it in the...
Okay, no, I've already answered.
Oh, you
Just to
answered it.
tell the group, routine use of dual antifungals is not recommended by the IDSA and other guidelines. So the only place would be in any resistant fungal sepsis, probably like Candida auris, etc., wherein you have a resistance being proven, or else in extreme cases of meningitis caused by cryptococcus, especially in HIV-related patients. Otherwise, routinely, dual antifungal therapy is not advocated.
Yeah.
Okay. So I'll go ahead with the next class. I think so. This is something that is my slide visible?
No, sir.
Okay, just a minute. I think so. Now it should be visible.
Yes, sir.
Nice. Okay, great. So this is one of the topics that routinely is going to be asked, nevertheless, and as intensivists, we are going to face it day in and day out. So I thought this would be practical in both the ways for us to discuss it. There have been a couple of questions which have been asked in the exams recently, more often in terms of evidence related to de-escalation, what is fluid stewardship, etc. Okay, mostly they've asked about the ROSE concept or SOSD, or else they've asked what are the 4Ds of fluid resuscitation, something like that. Okay, so coming to the presentation per se. So we know that the latest surviving sepsis guidelines was given in 2021, okay, in which they suggested that at least 30 ml per kg of IV fluids of crystalloids should be given within the first 3 hours. Along with that, what they suggested is the use of dynamic markers for fluid responsiveness to initiate or carry on with fluid resuscitation. Both of this, as we can see, are weak recommendations with very low quality of evidence. What is more stark is when compared to the 2016 recommendation of the SSG, the recommendation was downgraded for the 30 ml per kg of IV fluids because they had solid evidence from the trials like Process Promise and Arise, which showed that one size fits all is not going to be the way forward, because there are a lot of effects of fluid resuscitation, and fluids need to be treated like drugs. That is what they emphasized on. Okay. So where did all this start? It all started in 2001. Actually, the start of the millennia was when the whole world looked at EGDT, because it was a protocolized approach for the management of septic shock. It was a very great way of resuscitation, because there was one protocol which was given and universalized later on for almost a decade, okay, wherein it showed few of the markers which could objectively be used for a septic patient so that we achieve certain goals. So we are in the same way. So this was what was challenged. So after 10 years of this, the Australasian group and others tried to look at the effects of the EGTT on mortality, or was it, based on evidence. So the ARISE trial was published in 2014. They used the map target of more than 65 of Hg, and the initial fluid bolus was 1 liter of crystalloid within the first hour. The average fluid volume within the 6 hours was found to be roughly around 2.5 liters. What they found out was there was no significant mortality difference between the EGDT guided resuscitation as compared to usual care. So they found out that a protocolized based resuscitation was not superior. This was reflected in the other trials which were following it, that is the process trial and the promise trial. In this also, you can see that the initial fluid bolus was roughly around 20 ml per kg, with a mean volume in the 6 hours being 2.8 liters in both the groups. So roughly whatever said and done, what the overall summary said was there was no mortality benefit with early goal-directed therapy. There was no survival advantage with the protocol-based approach as seen in EGDT. 90-day mortality was similar across all the groups. The standard, care of evolution, which usual care is what it is referred to as, was something that evolved from reverse trial. Okay. Early recognition and treatment of sepsis, which was the hallmark of the study, became universally accepted. Protocol flexibility is what was called for. So the overall impact led to more individualized approach to sepsis and less aggressive fluid resuscitation. Okay, so this leads us to the most important question. How do we approach a case of septic shock? So EROS is the latest concept. What I want you guys to understand is, in this class, I'll not be talking about fluid responsiveness, which has already been dealt before, okay? Only practical concepts related to fluid resuscitation is what we are going to discuss. The 4 pillars of the EROS concept involves an early recognition of the shock stage with identification of the source of infection. Along with it, resuscitation and rapid establishment of tissue reperfusion is what needs to be achieved. Providing organ supports, especially when it is failing, becomes very much necessary for preventing the further cascading effect of septic shock. Source control includes early adequate antibiotics, drainage or debridement of the infectious focus as early as possible. So these is what comprises of the EROS, that is early recognition, resuscitation, organ support, and source control. So in early recognition, what we need to focus is on clinical examination as well as history, use point of care ultrasonography, appropriate imaging whenever it is necessary, and microbiological sampling and culture with initiation of antibiotics as early as possible. Okay. Resuscitation is starting of adequate, fluid therapy, timely initiation of vasopressors, inotropes if required, and transfusions if necessary, especially in case of a major trauma like a open, fracture, etc. Organ support is early initiation of invasive mechanical ventilation, renal replacement therapy, and extracorporeal, therapy whenever it is required, as and when the resuscitation progresses. Source control is the main pillar of the EROS concept. We need to make sure that if there is a source of sepsis, that needs to be identified at the earliest and has to be mitigated. Otherwise, doing any other thing would be futile. So whenever we get this patient, these are the things which we usually look at in our examination. So we look at the vital signs. Usually they would be abnormal, indicating a drop in blood pressure, tachycardia, tachypnea, with probable raise in temperature, because of which there would be poor tissue perfusion. leading to delayed capillary refilling, mottling of skin, cold extremities, and decreased urine output. Along with this, what other thing would we look at? Usually they are called as 3 windows of shock, especially in septic shock. One is skin that or delayed capillary refill. The other one is urine output. Other one would be the third window is the mentation. Okay, that will also be down. And laboratory markers, as indicated in any shock stage, usually leads to elevated lactates, base deficit, and SCVO2 of less than 70%, and blood gases would be usually showing a trend towards metabolic acidosis. So what would we do? You've already taken the history, you've done in some labs, and you've got some values which indicate towards a shock state. So according to the surviving sepsis guidelines of 21, what it initially suggests us to do is administration of a crystalloid for a 30 ml per kg volume within a span of 3 hours. After this, it asks us to reassess the volume status and tissue perfusion. If found adequate, stop the fluid bolus. If inadequate, that is, if the lactates are still high, if the patient is hypotensive, probably we need to consider addition of vasoactive agent, or probably another fluid bolus might also be suggested. So when do we say it is adequate? Usually the targets are a MAP of more than 65 mm of Hg, an SCVO2 of more than 70%, or normalization of lactate or lactate clearance. So based on various trials which have been done, especially the ARISE trial, as latest as the Andromeda shock trial, what is the lactate clearance that is advised as, which is significant? I need you guys to unmute and answer this question. It's your Viva question also.
10% lactate.
Excellent. Up to 10% is suggestive of significant lactate clearance. Okay. So anything more than 10% is great. If you have a 20 to 30%, that means to say the resuscitation has been, very good. Or else the patient has a better chances of, getting out of the septic circle. Okay. So whenever you reach these targets, you can stop fluid resuscitation. So in resuscitation, the goal of resuscitation is to rapidly establish tissue reperfusion, thereby increasing the delivery of oxygen and maintaining the oxygen content of the blood, and by in turn also maintaining the neat arterial pressure. Okay. So the goals of resuscitation involves restoration of the volume, support of the blood pressure, improvement of cardiac contractility, and replacement of lost blood components, if any. How do we do it? That is restoration of volume by fluids, blood pressure by vasopressors, contractility by inotropes, and lost blood products, if any, by transfusion of blood products. So fluid management in sepsis and septic shock, the basic concept, you have a vasodilatory stage which leads to maldistribution of bloods to organs. That is, there is no high quality evidence to show that there is, if at all you give a large volume of fluid, it is beneficial. Okay. Many times that has been seen that we use this IVC collapsibility, even SVC collapsibility, or the use of CVC as one of the parameters to see that. But there is no robust evidence to show that this can give us an example or a guidance tool for better resuscitation. More or less, what usually happens in this phenomenon is in a state of volume overload. So always don't go by the concept of overloading the patient and subsequently diuresing the patient to reach the recovery status. Okay, because this concept has found to be a not viable concept or poorly, physiologically sound. So what usually happens is, because of volume overload stage, the euvolemia usually would be appearing after adequate resuscitation and probably after diuresis. When you go to the over-resuscitation stage, there is always a risk of damaging the endothelial glycocalyx, wherein it sets forward a vicious cycle of probably causing acute kidney injury or fluid overload syndromes in the patient. Okay. Fluid bolus therapy is usually not evidence-based. Whenever possible, use dynamic indices of fluid responsiveness and guide your therapy. So coming to a few terminologies which are associated with fluid resuscitation. What do we mean by resuscitation fluids? It is the fluid which is given to the patient in the initial phase of shock, usually targeted at perfusing the organs, which is usually done to normalize the lactates or have good lactate clearance. What is fluid creep? a term that refers to unintentional, unmeasured fluid volumes which are administered in the process of delivering other medications. That might be antibiotics, sedatives, painkillers, etc. It can also involve your NG feeds, okay, or any other enteral or parenteral nutrition. Maintenance fluids are fluids, a source of water, electrolytes, or any other potential source of glucose that is aimed at covering the basic caloric intake of the patient when he is critically ill. De-escalation and de-resuscitation usually involves the process of removal of excessive fluids in the body in the phase of fluid resuscitation. Okay. That is usually after you have finished your first two steps, that is salvage or resuscitation and optimization. Okay. Fluid creep usually attributes to around 33%, and nutrition attributes to roughly around 33% also. So these three things usually tend to be ignored in the ICU, and this is usually what adds on to the cumulative balance over time and causes volume retention in the patient, which can be detrimental in the long run. So what is the concept of ROSE? Usually it stands as an acronym for resuscitation, optimization, stabilization, or evacuation or de-escalation. As you can see in the graph, you have the cumulative fluid balance in the y-axis and time over the x-axis. What usually the resuscitation phase consists of is the fluid resuscitation, which adds on in minutes to several hours after the diagnosis of a patient being in sepsis with probable hypotension or septic shock. Usually, the target would be to give this patient around 30 ml per kg as the surviving sepsis guidelines within a span of 3 hours to achieve a target of 60 to 65 mm of Hg. So what do we do in optimization stage? The optimization stage usually happens from hours to usually the first 2 to 3 days of septic shock or sepsis. So what we usually try to target is the normalization of the capillary refill or the CO2 gap, okay, in such this thing. Basically, we are looking at adequate cardiac index. You're trying to reach that stage. Stabilization phase is the phase where you want to achieve euvolemic state. Okay. So usually this question might be asked in multiple exams as well. In which stage of fluid resuscitation do you want to achieve euvolemia? That is usually in the stage of stabilization. So that can occur between several days or towards a week. Okay. And de-escalation is usually over a period of a week. And therein you try to remove excessive fluid in the body. Okay. That is post resuscitation. So what usually is suggested is, as compared to the surviving sepsis guidelines in resuscitation phase, use smaller boluses, that is up to 4 ml per kg. If they ask you about ROSE concept, start with this, okay? I've told you in the previous slide, it's about SSG, correct? So in the ROSE concept, what they asked is, but instead of 30 ml per kg, start with a smaller bolus, that is 4 ml per kg, and start with early norepinephrine. To usually when the patient's diastolic shock index is more than 2.3, or the diastolic BP, which indicates a state of vasodilation, being less than 50 mm of Hg, start early norepinephrine. In the stage of optimization, what would you do? The intervention is usually to check the fluid responsiveness, usually use dynamic markers, and start adding colloids in such state. Usually what is suggested is the use of albumin. Based on the SAFE study and the Albios study, what usually was found is whenever there is large volume resuscitation that is necessary to reduce the volume of resuscitant fluid necessary, it can be substituted by the use of albumin. Okay, it has not shown to be inferior, or sometimes it has also shown to have lesser length of hospital stay or the occurrence of ART, I mean, need for acute kidney injury and all of that. So in that case, you can use albumin. So that is what is suggested in the optimization phase. Coming to stabilization phase, as I've already told you, look for getting a euvolemic state. Okay, you can minimize the use of maintenance fluid, or if not necessary, please stop it. Okay, in this case, you have to look into the fluid creep, which might have happened in the first 2 to 3 days or up to a week. Okay, because of multiple infusions which the patient might have received, like sedation, or probably even nutrition wise also you might have given a lot of fluids to such patients. So that has to be optimized in this phase. In the evacuation phase, Usually, you tend to get the patient back into a little negative balance or euvolemic status. That time you might have to use diuretics. If diuretics are not working and this patient is still looking a little volume overloaded, then you might consider the use of ultrafiltration if needed. Okay, it might be with or without the use of albumin. So coming to the next thing, okay, so what fluid do we use? So usually what is considered is colloids or crystalloids, right? So if the type of fluid is what you need to consider, so the current evidence does not support the use of colloid as the first resuscitant fluid, okay? So the theoretical advantage of colloids remaining in the intravascular compartment for a longer period, thus potentially limiting the overall resuscitation fluid, was futile. I mean, it was not sound. So SSG clearly says that don't use colloids as the first thing. But if you're thinking of colloids, the best thing would be the use of albumin, usually in this optimization phase, as I've already mentioned in the previous slide. So the use of starches is totally, obsolete as of now because it has caused more damage than, benefit in the long run. The damage ranging from renal failure, coagulopathy, transfusion, and allergic reactions. So the success study especially showed that the use of colloids had a higher 90-day mortality as well. Okay. So use of hyporisoortic fluids like 4 to 5% albumin was found to be safer in septic shock. The cost benefit ratio is what needs to be thought about. Always remember, albumin should never be the fluid of choice, especially when you're resuscitating a patient with traumatic brain injury associated with raised intracranial pressure. So if you have a patient with TBI, if you're thinking of albumin, stick no. You know why. Okay. So it can usually cause raised ICP. Okay. So that is one of the reasons you need to consider this. So this might be one of the questions they might ask you in your Viva session if you take up albumin. Okay. So they might trick you by telling you the patient, in day 2 has fever, septic shock has come in, I'll give you albumin. Do you want to give albumin? Probably the patient was mild to moderate TBI, did not get any decompression at that time, and still you're using anti-edema measures. So be aware of such things, okay? TBI, there is no role for albumin. In a small study, as I told you earlier, whenever the volume of resuscitation was high, if the use of 20 to 25% albumin was only beneficial to reduce the volume of resuscitation. Okay, but still larger trials need to be used for us to come to a conclusion. The Albios trial showed that supplementation of 20% albumin infusion in addition to crystalloid infusion was associated with mortality benefit. So this is one thing that they found out. Okay, so this is something that I want you guys to remember, that what I need you to remember here is it was in addition to a crystalloid infusion. So first choice is always crystalloids followed by colloid, that is albumin, only albumin and not starches at all. Okay. So next question is crystalloids versus balanced salt solutions. So what is the role right now? What do you guys have? I mean, you guys might have been told about this multiple times, right? So what is the problem statement with the use of crystalloids and balanced salt solutions? Okay.
With saline, hyperchloric metabolic acidosis can occur.
Correct. So that's good. That's good. Okay. So that one of the major problem was the high chloride load and potential for renal hyperperfusion through tubulogranular feedback mechanisms, which are usually seen in crystalloids. That is usually the saline, that is 0.9% saline, but we routinely use as a resuscitant fluid. The strong ion difference was found to be around 0, and the causation of hyperchloremic metabolic acidosis was high. So even though they say this, the surviving sepsis guidelines clearly indicate that the balanced crystalloids is the first resuscitant fluid that we need to consider in the patient with septic shock. Okay. What is the evidence for balanced crystalloids versus balanced salt solution versus crystalloids currently?
Split, smart trial,
Yeah,
basic,
great. Some more?
basic
Okay,
split.
did they find any benefit?
Um,
Basics trial was there recently, or any other thing?
The situation illness and crystal balance salt are same, almost
Okay.
same.
Good. What did they find out? Was there any benefit? See, the whole concept is we thought that is metabolic acidosis. Metabolic acidosis can cause problems to kidney. So what they looked at is what is it causing? Well, first thing, is there any mortality benefit? That is what we need to look at most of the trials, right? In critical care, most of the things are focused at mortality benefit. The second thing, usually what they look at is renal replacement therapy, acute kidney injury, or organ damages that is associated. So what they usually looked at all of this is make 30, okay? Made a adverse kidney events on the day 30. So what they found out was there's no benefit. I'll just discuss, okay? So restricting the use of chloride liberal fluids improved renal outcome. That is what they found out. That is balanced salt solution better than crystalloids, that is saline. The SMART study, like you all mentioned earlier, what they found was composite out, it had, use of balanced crystalloids, probably ringer, had lower composite death outcome, renal dysfunction, need for renal replacement therapy, as seen with make 30 events when it was compared with 0.9% saline. The SALT ED trial also showed the same thing, that is, reduce the length of hospital stay and lesser incidence of make 30. However, looking at the trials which I've already mentioned earlier, you see this particular table, I just want you guys to look at very closely and remember at least a few trials, okay? Whenever there is a question about balanced salt solutions versus crystalloids, this thing can come in your table viva, okay? So recently when we had our interaction session, most of you asked us how to speak about, a trial if it is given, how to go about it. I told you about the use of PICO questionnaire. So this is how it is usually summarized in major articles as well. See, if you can see here, it is the population, intervention, comparison, and outcome. So this is how we have to go through. So when we see here, it is actually put it in a chronological order from the year which was published, okay? So in this particular study, what is our focus on? Balanced crystalloid solutions versus normal saline. So this patient population, it is all the ICU patients, okay? And the intervention group usually consists of the balanced salt solution. The comparison was in normal saline, correct? So this is what usually you need to see. And then you need to have to look at the outcomes. In the trial, if at all it is given as your critical appraisal paper, look at the primary outcome and the secondary outcomes, okay? So you need to usually talk about them. In the statistics class, we'll let you know how to go about each one in a small format, okay? So this is usually the way that you need to write as well, if that all they ask you in a exam also. So they might ask you a question, write about the evidence of balanced salt solution versus novel saline and septic resuscitation or something like that. So critically analyze or something if they ask you in that lines, you need to answer in such headings, okay? So what we can see is they have done a large intervention. So the base trial was one of the recent one. After that, plus trial came in. So until up to the split and the salt trial, along with salt, there was another trial I mentioned earlier, the salt ED trial. Okay, so what they found out was there was no major difference which was seen. Later on, SMART trial showed that the use of balanced salt solutions was, leading to lesser occurrence of renal damage as well as the need for renal replacement therapy. Also going on to show that it required lesser hospitalization. But that was actually offset by basics trial. They saw that they told that there was no significant decrease in the acute kidney injury and mortality within 90 days. But when they did the subgroup analysis, they found out that there was a higher 90-day survival in patients who received balanced crystalloids. Okay, so that again put us into a lot of debate as to what happened. And then subsequent year in 22, there was another study which was published, that is the PLUS trial, which again went back to the initial evaluation, showing that there was no difference. So currently, whatever is said and done, what they're asking us to do is the use of balanced salt solution is theoretically sound and physiologically sound. So whenever possible, use balanced crystalloids as much as possible and avoid normal saline. Okay, so the thing in these two trials, there are a lot of biases which were there. So if you go to the study per se and then read about it, you will understand. For now, practically speaking, because these two are something which is major, that is occurrence of acute kidney injury in the ICU stay, probably the use of balanced crystalloids is good. Okay, so to take home point in this particular question about balanced solutions versus normal saline, use balanced crystalloids as much as possible. Okay, and that would be answered by two things, that is length of hospital stay and occurrence of make 30 events. Okay. So the next question would be the dose of fluid. So how do we dose? We already spoke about 30 ml per kg within the first 3 hours in SSC guidelines. So, but this was widely criticized, right? It got downgraded even from the recommendation guidelines to a suggestion guideline from 2016 to 2021. What usually happens is the evidence for this was lacking in most of the trials, which was already mentioned previously. So this is one of the limitations of surviving sepsis guidelines as well. Okay. So they usually consist of a lot of RCTs, which are usually not powered to what effect we want to look at. Okay. So weight-based fluid resuscitation is something that needs to be individualized. And that would be futile if you take just a round number of 30 ml per kg for all the patients. Along with that, you need to know the hemodynamic status of the patient as well as the comorbid illnesses of the patient. So for this reason, what they found out was if you use 4 ml per kg body weight, as mentioned in the ROSE concept, that would be a little more judicial way of approach to dosing the fluid in sepsis and septic shock. So subsequent use of fluids should only be based on fluid responsiveness. That is usually what you need to do is use a dynamic test of fluid responsiveness to guide your fluid resuscitation. Fluid challenge should not be repeated, especially if you have a negative or an equivocal response to fluid responsiveness. So the next question would be when to initiate vasopressors. So we spoke a lot at length about type of fluid, the dose of fluid. But when do we start vasopressors? Anyone? See, these things should be answered quickly, okay? Because see, this is something you guys are doing from the time you join the course or probably before as well, right? So you will have some idea. Please commit to some answer so that we'll take it from there, okay? Don't worry about it being right or wrong.
As per classic and Clover trials, early vasopressor initiation is
Classic and Clover trial, okay. When did they say that? At what time? Any other trial which came up? Classic and Clover trial did not, actually they mentioned that, okay, but that was not focused at that, okay. So usually whenever we talk about this, no, we should see if it was intended to address that issue. Yeah, but that has subgroup analysis showing that. Excellent. Anything else? Early initiation means when? Okay. So in patients, whenever there is the diastolic blood pressure of less than 50 mm of Hg, you can start fluid and vasopressor. Okay. So this need not wait for your 30 ml per kg as per SSG or 4 ml per kg body weight with fluid responsiveness time and again to reach there. Probably you would have started a cascade of organ damage by then. Correct. What SSG says is wait for 3 hours. What Rose says is do it every 15 minutes to 20 minutes. Probably at that time, patient might have worsened and he would have required more organ support by then. What if the patient had gone into acidosis? What if the patient had gone to hypoxia requiring ventilation? So these things could have been offset, right? So that is what they said. Use of diastolic shock index, especially if it is more than 2.4, indicates the initiation of vasopressors. So it is usually reasonable to start vasopressor infusion after initial 1 to 2 liters of crystalloids. But if at all it is before that, you see these signs like above, that is the diastolic shock index or the diastolic blood pressure being low, you can start vasopressors as early as possible. Along with the trials mentioned before, the refresh study was usually focused on initiation of norepinephrine after 1 liter, and it had shown to reduce the cumulative fluid balance as well. Okay. So observational study dose of vasopressors in the first, whatever 6 hours of septic shock, if you delay it after that, it was shown to have higher mortality. Okay. So if at all it was initiated earlier and especially after 2 liters of fluids, the effects were found to be beneficial. Okay. So this is something, it is quite against what SSG advocates at present. Okay, so this is what I need you guys to understand. So whenever you have a patient with septic shock, don't wait for first 3 hours, 6 hours, etc. Start fluids, probably 1 liter or 2 liter, or based on the patient's comorbidities. Look for fluid responsiveness. If at all the patient is in shock, if you have an art-line in situ, or else you have checked the blood pressure to be less than 50 mm of Hg at the time of arrival, probably it is fair to start vasopressors after 1 or 2 assessment of fluid resuscitation. By this, I don't mean that as soon as the patient comes to your ER, check the BP. If it is 80 or 40, start NORAD. No, it doesn't mean that. You need to give fluid. You need to reassess the patient after 1 or 2 boluses and then start the vasopressor. Okay, I hope I'm clear about that. So coming to liberal versus conservative fluid therapy. So what do you guys understand by liberal versus conservative fluid therapy? So coming to the concept of liberal versus fluid therapy, this came into picture, especially after EGDT, surviving sepsis guidelines following that, coming and the use of various other trials like ARISE, process, promise, giving us larger volumes of fluid resuscitation to mitigate the organ injury due to septic shock. So what happened was there was large amount of fluids being pumped into the patients with sepsis, along with blood products in a few centers, which still followed EGDT. So the whole thing, if you see here, the population intervention comparison and outcome was wherever they used these things, they looked at the hospital mortality as the goal, okay, or the outcome. So in the EGDT, surprisingly, they found out there was significantly lesser in hospital mortality, especially with Apache scores and SAP scores and mods being reduced if they followed EGDT. There was another trial called the FEAST trial, which was usually the sub-Saharan African children, which showed that albumin boluses, if given to the patient, was associated with mortality. Okay, so this kind of got a lot of confusion associated. So then came the ARISE, promise, and process trials, which said that no, you can go ahead with around 20 to 30 ml per kg body weight, but still there was no mortality benefit associated with this particular volume. Over time, the recent trials like the classic and the Clover trials also looked at the use of restricted fluid strategy with liberal fluid strategy. Even at this particular time, the thing is there is no difference between liberal versus restrictive fluids, which is seen in the resuscitation of septic shock. So the question still remains. There were multiple other trials along with these things which looked at liberal versus conservative strategy. One being Andromeda trial, etc. Okay, so what they saw in Andromeda was the normalization of capillary refill time, lactate, and up to something some point even about the end-tidal carbon, sorry, not end-tidal carbon dioxide, the CO2 gap, that is the arteriovenous CO2 gap as well. Okay, so they looked at whether that can be normalized with restrictive group people. So even in these studies, they did not have any solid evidence to prove this. So we are still waiting few more trials which are coming. That is the ARISE. I'm not sure the part of it. There is one more ARISE which is coming. Along with that, there is the Andromeda Shock 2 trial which is coming. So probably these trials can help us understand so whether there is any new evidence which can come around liberal versus uh, restrictive strategy. For now, all that you guys need to remember is there is no difference between restrictive versus liberal fluid resuscitation and sepsis with septic shock, but it is advisable to avoid volume overload. That is something that we need to understand. So how do we do that? Probably start low, don't overload your patient. Always use markers of fluid responsiveness to guide your fluid therapy as and when possible. So how do we do the assessment of fluid responsiveness? It's already been mentioned before. Use of static markers like CVP or pulmonary capillary wedge pressure are not a good indicator. Use your dynamic markers, especially the PLR, pulse pressure variation, stroke volume variation if the patient is on ventilator and like test like end expiratory occlusion test and all can help you understand the fluid responsiveness in this patient. Okay, I'm not going into detail of this, but this is something that you need to understand when you're resuscitating the patient. Capillary refill time, as per Andromeda shock trial, has also shown to be beneficial when used for assessing the first to diagnose poor perfusion as well as normalization for improvement in resuscitation. So you can use it as a diagnostic tool as well as a target resuscitative tool as well. Okay. So anything capillary refill time of more than 4 to 5 seconds is said to be poor. Less than 2 seconds is supposed to be excellent. Okay. So what are the effects of fluid overload is what we need to understand. So till now, whatever we have spoken is about how do we start fluids, when do we start fluids, what fluids to start, how much to start, and when to stop. Okay. So you need to understand these concepts. Along with this, when you have already resuscitated the patient, there is always a possibility that we overdo, correct? Because there is no gold standard method wherein which says that, okay, you have achieved this target, you can stop. Probably your MAP would have achieved 65%, but still your lactates would be high. Probably the urine output is not good. It's probably, you're looking at cardiac contractility or ventricles being kissing or IVCs like, collapsing. So these are clinically possible scenarios that you will be looking at. And based on one of these things, you might have gone ahead and given fluids. So what usually happens, the patient usually ends up in a state of fluid overload that can be seen as tissue edema, pulmonary complications, cardiovascular effects, renal problems, coagulation problems, and other systemic issues. So usually these things can be evaluated by our VEXIS, right? So VEXIS is a great tool for us to know if the patient has gone into a state of fluid overload. So if at all the questions come about VEXIS, then you can talk about effects of fluid overload in these issues as well. Okay, first answer about VEXIS. And then if they ask you about other things, then you can write the principle or why it was done. It's because if you have tissue edema, it leads to impaired oxygen diffusion to the tissues. It can lead to pulmonary edema, increased work of breathing, and worsen the gas exchange. Cardiovascular effects, usually it leads to increased cardiac payload, probably dilutional effects on the hemoglobin and reducing the oxygen delivery. Excessive back pressure in the kidney can worsen the GFR. Okay, and in worst case scenarios, because of excessive fluid resuscitation, there can be risk of development of abdominal compartment syndrome leading to acute kidney injury as well. Because of dilution, there can be dilutional thrombocytopenia as well as coagulopathy, which can set in volume overload. Excessive fluid accumulation in tissues can cause gastroparesis, which is usually seen in septic patients. Hepatic congestion is usually seen as transaminitis, which also further goes on to worsen the overall outcome. Okay. So cerebral edema is one of the polycompartment syndromes as associated with abdominal compartment syndrome, which is also seen in case of fluid overload. So what do we usually do? So whenever you see this, always go by your ROSE concept or SOSD concept. So see if you have done one of these properly. If it is done in the correct order, that your fluid boluses are optimized, you have achieved neutral fluid balance, and you have started evacuating the patient, then it is okay. But if it is not, if you see one of your markers of fluid assessment is showing one of these, so that time probably you might have to start initiating this patient on de-resuscitation process. Okay. So we all know that fluid accumulation can cause a lot of problems. I've already mentioned to you earlier. So if at all you have this patient in one of these issues, the treatment would usually be initiation of loop diuretics. You can use a combination of diuretic therapy at that particular time. You can combine a loop diuretic with a thiazide or else a potassium sparing diuretic. Also, if the patient is in the ICU for a long period of time, your diuretics usually do not work if the albumin values are lower. Okay, less than 2.4 to 2.2, the efficacy of delivery of diuretics become a little difficult. So probably at that time, you can consider the use of albumin. It can help in both the ways. It can help in reduction of fluid resuscitation as well as better action of diuretics. Probably if this is futile at that particular time, you can think about isolated ultrafiltration, which can help in removal of excessive fluid in the body. Along with that, other supportive care to reduce the intra-abdominal pressure, abdominal wall compliance can also be thought about. So if you have reached all of this, probably the patient would clinically improve. Okay, so deresuscitation is the way forward, and the patient has ended up with fluid accumulation syndrome. This is not universally accepted. Most of the societies do tell that it is still theoretical because it does not involve everything together. Most of the time we see these things in isolation. Probably you see only acute kidney injury or pulmonary edema. Rarely you can even see gastroparesis. So this as a polycompartment problem is still not robustly studied nor has been usually accepted in most of the places. So coming to the concept of fluid stewardship, this might be one of the questions they can ask in theory. Okay, they've already asked once, what is the 4 Ds of fluid resuscitation? The 4 Ds of fluid resuscitation are drug, dose, duration, and de-escalation. What they mean to say by this is they're asking us to look at fluid as a drug. Okay, so it has to be dosed, it has to be for a particular duration, and it has to be stopped. So this is something that we need to understand. So the questions that you need to understand in fluid stewardship is the first 4 questions. That is, when do we start IV fluid? When do we stop the IV fluid? When do we start removing fluid? And when to stop removing fluids. Okay, so this is very easy to remember. Starting, stopping of IV fluid, when do we start removing, and when do we stop removing? So this is something that we need to understand. So all of this you can remember by putting the graph of the ROS concept. Okay, that is your resuscitation, optimization, stabilization, and de-resuscitation. So when you're using that, you will understand. And this is the first 4 questions that need to be addressed in fluid stewardship. These things usually maintain based on resuscitation, maintenance fluid, replacement fluids, and nutritional part of the IV fluid. So if at all this is not done, so if you continue, erroneously continuing the fluids for a longer time, usually this leads to multiple hits. That is, the first hit is the initial insult. Okay. The second hit would be because of ischemia and reperfusion. And the third hit usually happens because of fluid accumulation and global increased permeability syndrome. This is something which is also seen in cases of dengue. Okay. So, and the fourth hit is because of organ damage, which has happened because of fluid accumulation. So we need to understand that we need to prevent these 4 hits. Okay. So this is what is roughly about fluid stewardship. So the take-home messages is fluid resuscitation remains a vital part of management of sepsis with septic shock. Use balanced crystalloids and with frequent assessment. Assess for endpoint of hemodynamic resuscitation. So you should always know one thing about this. Okay, when do we stop? That is something that we need to know. Okay, so early introduction of vasopressors may be necessary. And remember, the goal is to optimize and prevent end organ damage whenever we are thinking of fluid resuscitation. Thank you. Any questions? So, guys, I guess we need to have more participants. Okay, the thing is, we need you to react. React, respond, or ask whatever you want, so that we'll be able to help you in the long run. So the next topic would be hyperbaric oxygen therapy. Okay. So this question has not been asked till now, but what we are looking at is many of the things in the current exam patterns are, especially the latest advances. So sepsis, mostly they were asked a lot of things prior. What we saw in the current critical care update book, that is the 24 update, was the role of hyperbaric oxygen, immunomodulation, etc. So we added these classes especially because these might be one of those sub questions which may be asked in your exam. Okay, it's not like it is very important. It is routinely and widely used in most of the centers. But since it is there in the update book and it is being stressed upon, maybe this is something that you need to know. And recently, even in fungal sepsis, I think so. You guys, heard about the use of hyperbaric oxygen therapy. So the outline would be under the following headings: introduction, principle, methods, uses, and contraindications. So whenever they give you a bouncer question like this, always divide it under these headings or any headings, whatever comes to your mind, and then answer them in that. So if you don't remember anything also, you will be able to answer 1 or 2 sentences in these headings. Probably that will help you fetch a few marks. Okay. Always, it's better to get 2 or 3 rather than getting a 0 out of whatever marks there, right? So that is the whole goal in a bouncer question. So hyperbaric oxygen therapy in critical
There is
illness.
slides are not visible, sir.
Oh, is it? Sorry. Is my slide visible now?
Yes.
Okay. I'm sorry for that. So as mentioning earlier, you need to answer these questions under the headings of introduction, principle, methods, uses, and contraindications. If they ask you about any method per se, you can use this. Depending on the type of question asked, you can modify the headings, okay? So in hyperbaric oxygen therapy in critical illness, the basic concept revolves around the use of 100% oxygen under atmospheric, more than 1 atmospheric pressure. The usual thing is 1 atmosphere. Whatever is beyond that, usually it's 2 to 3 atmospheres what is targeted as, okay? So it is usually delivered in specialized chambers and creates a hyperoxygenated state. The primary mechanism which it revolves around is increased dissolved oxygen delivery in the plasma, and it usually is independent of the usual or the routine hemoglobin transport of oxygen, okay? So the critical care applications usually revolve under very specific conditions that I'll be mentioning in the further slides. Usually used in various life-threatening situations like carbon monoxide poisoning, central retinal art occlusion, I'm sorry. Along with that, like, decompression sickness, etc. It has also been shown to have grade 1 recommendations in severe infections related to gas producing organisms, especially gas gangrene. So the key concept of use of hyperbaric oxygen therapy is the combined anti-inflammatory effect, especially which is seen in pro-inflammatory status, okay? Along with the effects of hyperbaric oxygen on bacteria, that is the antimicrobial properties, angiogenic properties, that is in the enhancement of wound healing, and in patients with probable transport issues, that is usually seen in cases of carbon monoxide poisoning or one of the toxemias, that is to improve the tissue oxygenation. Okay. So what is the whole thing about, hyperbaric oxygen therapy that you need to remember? The key points are usually, as you can see in the image, there is a patient. It requires a specialized chamber in which the patient is usually placed. The first and foremost thing is the patient gets 100% oxygen at 2 to 3 atmosphere. There will be multiple sessions, okay? The sessions are usually based on the condition. So what does this do? It helps in producing higher external PO2, which creates a positive gradient, and oxygen diffuses through the alveoli into the bloodstream. Okay. And this creates increased tissue oxygen delivery, which is independent of hemoglobin. This is very much important and very much possible only because the atmosphere, what we are using, the pressure is 2 to 3 atmospheres. Okay. Physiological effects which happens because of this way of transport of oxygen is hyperoxia and hyperoxemia. That is, hyperoxia refers to the tissue delivery. Hyperoxemia is the presence of oxygen in the blood. Okay. By this, it reduces the tissue hypoxia, thereby increasing the production of reactive oxygen species and reactive nitrogen species. Okay. This usually helps in upregulation of certain growth factors, promotes neovascularization, and enhances immunomodulatory properties. So this is the key principle. Put the patient in one of the chambers whenever it's necessary. Usually 2 to 3 atmospheres. It causes transport of oxygen from the alveoli to bloodstream to the tissues, especially it is independent of the amount of hemoglobin which is present in the body. It causes hyperoxia and hyperoxemia that leads to production of reactive oxygen species and nitrogen species, which causes upregulation of growth factors, neovascularization, immunomodulatory properties. Okay. So the angiogenesis is usually because of the production of epidermal growth factor and vascular endothelial growth factor and the increase in production of endothelin-1 that is associated with increased tumor necrosis factor alpha, increased matrix metalloproteinase 1, and tissue inhibitor of metalloproteinase 1. Okay. So this usually causes the production of angiogenesis. So the other property is the antimicrobial property. This causes downregulation of neutrophil activation, decreased WBC rolling. It also causes the decrease in production of TNF alpha and interleukin 6 and decrease in interleukin 10. Okay. This is usually the pro-inflammatory markers. What it usually does is it increases the anaerobic bacterial killing and also causes biofilm shrinkage. The immunomodulatory action of hyperbaric oxygen is because of increased production of antioxidants, which causes a production of decrease in production of nuclear factor kappa beta and decrease in interleukin 6, which has direct effects on the T helper cells. Okay, so what usually is the angiogenesis enhancement is something which we see in the flaps or the wounds whenever it is focused on those things, especially when you have that angiogenesis is suboptimal or the wound is chronically not healing. At that particular time, if this was initiated, they found better results. And that particular time, the mechanism by which it enhances wound healing is the improvement of angiogenesis. What we are focusing is morely towards the antimicrobial activities, especially due to the downregulation of certain pro-inflammatory markers and usually causing anaerobic bacterial killing and biofilm shrinkage along with immunomodulation. Okay, so this is what we are more focused at. So what are the indications for hyperbaric oxygen therapy? As I've already gone through this, there are 14 to 16 indications which are actually grade 1 indications, and mostly it involves around the gas embolism, carbon monoxide poisoning, serial clostridial myositis or myonecrosis, decompression sickness, refractory osteomyelitis, etc. Okay, crush syndrome is also one of the things, and chronically non-healing ulcers or poor flap uptake is also another indication. So they can be divided into multiple ways. That is emergency indications that is seen in decompression sickness, gas embolism, spinal artery cord infarction, central retinal artery occlusion, and carbon monoxide poisoning. Urgent indications usually seen in trauma, sensory neural hearing loss, and compromised flaps or grafts. Elective indications is usually seen in late radiation tissue injury, hypoxic wounds, chronic refractory osteomyelitis, and avascular necrosis. So what we are usually focused on in the current thing is the antimicrobial effects that is usually seen because of increased neutrophil function, increased antibiotic efficiency, biofilm disruption, and increased oxygen free radicals, which causes antimicrobial effects. Okay, so the other things like wound healing, angiogenesis, and medical emergencies, it's quite straightforward to understand. In wound healing, it basically improves the growth factor production, whereby it improves angiogenesis and recovery. In medical emergency, it is the oxygen cascade which we were looking at, which is independent of the hemoglobin and the gradient which is present. So at that particular time, it helps in better supplementation or delivery of oxygen to the tissues and prevents effects of hypoxia. Okay, so coming to hyperbaric oxygen therapy in sepsis, you can remember under these 4 headings, that is direct antimicrobial effect, anti-infective effects, influence on the host immune system, and adjunct to antibiotics. Okay, so coming to the direct effect of hyperbaric oxygen therapy, it is usually as an antimicrobial. It induces the oxidative stress, whereby it disrupts the nucleic acids, which in turn leads to protein breakdown. So that leads to its antimicrobial property. I'm repeating it again. It induces oxidative stress, that is usually by the production of reactive oxygen species or reactive nitrogen species, wherein it breaks the nucleic acid, which acts to act forward to help in building of proteins. So that is disrupted. So there's no protein, or there will be protein breakdown, which leads to antimicrobial property. So the effect of hyperbaric oxygen therapy as an anti-infective is either as a direct bactericidal or a bacteriostatic effect. It usually acts as an additive or a synergic tool, especially with the use of certain antimicrobial drugs like aminoglycosides, trimethoprim, sulfamethoxazole, and vancomycin. Always remember, hyperbaric oxygen therapy per se is not found to be superior for sepsis. It has to be used as an adjunct. Okay, so first, whenever you have sepsis, you can't start the patient on hyperbaric oxygen therapy. Start these patients on the routine way of treatment. Probably it can be used as adjunctive therapy, especially in resistant organisms. So you can write hyperbaric oxygen therapy as known modalities of treatment for sepsis with resistant strains. Okay, so there are a lot of treatments which are coming forward, like phage therapy, monoclonal antibodies. Okay, probably extracorporeal therapies. In one of those, we can also add a hyperbaric oxygen therapy. Okay. So hyperbaric oxygen therapy's influence on host immune system is basically it causes overexpression of growth factors and downregulation of chemokines, especially the pro-inflammatory markers like interleukin 1, interleukin 6, and tumor necrosis factor alpha. Hbot, I told you, it is adjunct to an antibiotic. Okay, it can never act alone. Most of the times, it is usually causes anaerobic conditions, which causes the lysis of the bacteria or fungus, which is there. Okay. What are the contraindications of hyperbaric oxygen therapy? The absolute contraindications are untreated pneumothorax because it can risk, I'm sorry for the error there, risk of worsening due to pressure changes. Concurrent use of certain medications like doxorubicin, cisplatin, and bleomycin. Okay, usually it causes potentiation of toxicity exacerbation with doxorubicin. Cisplatin, it causes reduced efficacy. Bleomycin, it can increase the risk of pulmonary toxicity. Bleomycin as it is can cause pulmonary fibrosis, but by the use of bleomycin with hyperbaric oxygen therapy, probably will be fastening the process of pulmonary fibrosis. So that is why whenever the patient is on bleomycin, there is no hyperbaric oxygen therapy is absolutely contraindicated. If the patient has any middle ear or a sinus surgery, it is contraindicated. Relative contraindications are patients with severe COPD, probably because they might have bullous lesions and that can cause, a barotrauma or a pneumothorax. History of seizures. If the patient is already having seizures and is on anti-epileptic therapy, as we all know, Hbot effect is one thing which happens. There will be increased production of reactive oxygen species in the brain, and that can reduce the seizure threshold, and that is going to trigger a seizure in that patient. Okay, so that is one thing I need you to remember. Also, remember we saw that there's a huge chamber in which the patient has to be placed. So if at all monitoring of the patient becomes problem, one is that is the relative contraindication. The other thing is patient would not be comfortable in that because of claustrophobia. So that is a relative contraindication. Pregnancy, optic neuritis, recent thoracic surgery. These are all things that they have still to be studied. So larger trials are not there. Pregnancy, especially the effects of hyperbaric oxygen therapy in fetus is something that is still being studied. So these are all relative contraindications for hyperbaric oxygen therapy. So remember, hyperbaric oxygen therapy is one of the newer modality to treat resistant strains. It is mostly as an adjunct. In sepsis, it can be both, antibacterial or antimicrobial, both antifungal as well. Along with this, you need to remember that it causes oxidative stress, disrupts the nucleic acids, and breaks down the proteins, so that thereby enhancing the killing of the bacteria. So downregulation of pro-inflammatory markers is also something that we need to remember, that cytokine storm part of any sepsis can be mitigated by the use of hyperbaric oxygen therapy. Okay, so these are the slides. Thank you. Any questions? You guys are free to ask. Recently in the session we had, you guys had spoken about how to approach or answer drugs, and I've seen the chat box that few of you have asked for, how to answer drugs. I recently had presented in one of the places, and then I have few slides. I just like to show you those slides. Okay, what book Srihari has already shared. I think so. It's a very nice book, and that was one of the books that even I studied for my exam long ago. So this is one thing I wanted to share with you guys. Just give me some time. Yeah. Okay. So whenever they ask you drugs, right? So they answer them under these headings. That is, antibiotic class, dose, mechanism of action, and adverse effects. And this is something that I just wanted to add because I have some time that I can spend to you. There are a few drugs which have already been uploaded by Dr. Bhuwana in the recorded sessions. You can go listen to them. There are a few antibiotics, especially the newer ones, which she has already mentioned there. Okay. But in case they ask you drugs, usually it will not be for more than 3 marks or 4 marks. It will be as a subheading. So whenever they ask you as a sub question, better answer them under these headings. So if you answer them under these headings, you would usually get most of the marks that is necessary. That is antibiotic class, the dose, mechanism of action, and adverse effects. So here I'm just taking an example of ceftazidime. It is a third generation cephalosporin. What you need to remember is it is active against gram-negative bacteria that we all know. But adding the point that it is active against even Pseudomonas is something that it is necessary. That is, it's an anti-Pseudomonal antibiotic. So you need to know the dose. It is 1 to 2 grams every 8 hours. Okay, 8 to 12 hours. It's usually administered. You should also know the route of administration. We all know cephalosporins acts by inhibition of bacterial cell wall synthesis. That is, it binds to the penicillin binding proteins and disrupts the peptidoglycan cross-linking. So always remember adverse effects. Please mention your regular, nausea, vomiting, etc. But more than that, what you need to understand is there are a few things that has to be addressed in a particular antibiotic. So you need to mention specific things like if it's imipenem or any other carbapenems, mostly imipenem, you need to mention about seizure. When you're talking about fluconazole, you need to mention about, immunosuppression. You have to talk, bone marrow suppression. You need to talk about all those things as well. Okay. So I'm talking about the next drug, linezolid if you're taking, right? So in this as well, you need to know what it acts on, whether it is a static drug, whether it is a cidal drug. These are things that you need to talk about. Okay. As we all know, linezolid causes myelosuppression, thrombocytopenia, something that we see, right? So this is something that you guys need to mention about. So each drug has its specific thing. Make sure that you guys write a few things about this and keep beside so that, when it's exams, you don't have to run around. If you've answered in such headings, probably you will be able to remember it in the long run. If you go read textbooks again during your exams, it'll look Herculean and you might feel scared also. So instead of that, gather 2 or 3 points and then mention it. So that will be helpful for you. Okay. We will be sharing a few slides like this once in a while so that it will help reduce your burden of preparing it. I know it's really difficult at this point in time where you have to read a lot of things. We will try and provide such summaries as and when possible. Okay. We'll put up a few slides like this each day so that it will help you guys. So this is what we thought we can do best. So another thing is you guys are asking about transplant. We are going to start talking about brain death, end of life care, etc., and management of a potential organ donor in the next session, that is next Sunday. But organ transplant per se, we will be trying to cover at least 1 or 2 transplants. Probably liver transplant is what we are thinking of covering in the miscellaneous section. So I think so that should help you understand a basic outline to how to answer a transplant related question in your theory paper. I think so that should help. Any question? Okay. If that's not, I think so. You should wind up for the day. It's been a long session. Thank you for waiting and listening. Anything you guys need to ask for any other thing? Thank you. Thank you, everyone. Good night. Obviously, I think so we can close, right?